We're just giving folks another minute or two to join and then we'll get started. Thank you, everybody. Good morning, everyone. My name is Rebecca Sannon, and I am the President and CEO at the Health and Welfare Council of Long Island. I'm so pleased to welcome you here today to our Techquity and Transformation Conference. And it's a wild thing to be hosting a conference about Techquity on technology. We may be physically apart today, but we are absolutely together, standing together as a region to build a brighter and better region for all of our communities and all of our families. Before we get started today, I want to thank our board under the leadership of David Nemiroff. And I, of course, want to thank all of our sponsors, especially our platinum sponsor, Morgan Stanley. I also need to thank our fundraising committee who made it possible for us to offer this conference to you free of cost. And folks who are on that committee are David Nemiroff, Jose Calderon, Ashley Chauvin, and Colleen Merlot. We are so grateful for your help and all of your support. A few housekeeping items as we get started. All of you who are on as attendees are in participant mode, but you do have the option to interact through the chat feature. Please be sure to change your messages to be sent out not just to the panelists, but to all panelists and attendees. You do that by just clicking the drop-down option when you have the chat feature open. That way everybody can see what you've said. For our opening speaker, as well as our keynote, we will have time after their presentations for questions. And we really encourage you to submit questions, selecting the option to send all your questions again to all panelists and attendees in the chat. I will then be able to ask them of the folks who are speaking. You should have received our conference program via email prior to today. However, if you haven't received it, there is a link in the chat today. And it has all of the bios as well for our speakers. So if you'd like to learn more about them, we are so fortunate to have just outstanding folks on today's conference. So we are here today in many ways because of what we've learned during this pandemic, right? We've faced a crisis, and a crisis presents opportunity. This crisis has many casualties, from loss of life to loss of security to loss of well-being, and for many of our neighbors, loss of hope. And it is our responsibility to reignite that hope, to reinvigorate our region, and to build a foundation that is stronger, much more equitable, and integrated as we design a better future together. To build that future together, though, we must stop, we must pause, and we must reflect. We don't want to just return to a pre-pandemic Long Island. We want to emerge better. We want to emerge more whole, more just, more strong, and filled with economic opportunity for families and businesses throughout our region. In many ways, we have lived through twin pandemics As COVID-19 ravaged the globe, here in the United States, we found ourselves at the center of multiple civil and human rights crises, culminating in the fabric of our democracy being threatened at its very core. This past year, we have borne witness to unconscionable horror, hate, and ugliness, but we have also witnessed the awe-inspiring power and the audacity of hope. We have witnessed how powerful we can be when we serve each other, and how powerful we can be when we dare to be creative, take new chances, and try new approaches. Pre-pandemic, before COVID-19 hit us, about 31% of households in Nassau County and about 39% of households in Suffolk County struggled to meet a basic survival budget, meaning putting food on the table, keeping the light and the heat on, having access to transportation and childcare. These are staggering statistics. Long Island's first suburb, a place of promise in post-war America, was founded with promise for some, but not for all. Restrictive racial covenants aim to keep homes all white, as were recommended by the Federal Housing Administration to keep our communities homogeneous. Robert Moses, for whom our beaches and highways are named, bulldozed communities and making room for urban renewal and actively discriminated in regional planning. And that was, around 1947. Discrimination was codified, engendering the systemic racism that endures today, despite Long Island's increased diversity. The Long Island we live in today basically guarantees that zip code determines everything: your health outcomes, your educational opportunity, your social mobility, and so much more. That was the Long Island we built at our inception. But today we have a moment in time more ripe for reform than any time in my lifetime, any time in your lifetime, any time in our lifetimes. Washington, D.C. is in the business of infrastructure today. We must make sure that infrastructure includes not only hard infrastructure, things like sewers and roads, but human services infrastructure. If we join together in the vision of a brighter future for every Long Islander, if we recognize that what happens to a child's life in one community impacts that child, that family, and that community, but also each of us, then we can harness our innovation and creativity and build a regional plan that recognizes our history, but builds our future. Today's conference will feature remarks and discussions from leaders and experts in the field of care, technology, and bridging the digital divide. And that digital divide so plagues our region. Let's use today as a moment of pause and reflection. Let's use it, though, too, as a moment of inspiration. But most importantly, let's make sure that today is not just a conference, but that it's truly a call to action. We have for far too long accepted our challenges as Long Islanders as inevitable. COVID-19 has unmasked, if you will, the devastation that happens when we become complacent, when we simply accept the disparities that were part of building Long Island's initial infrastructure. Today marks a new opportunity. Today, we are the architects of our future. Let this conference be a catalyst for an exciting, equitable future ahead that truly serves generations to come and builds a path forward that harnesses the potential and the value of every single Long Islander. Thank you. To kick us off today, I'd like you to please join me in welcoming Dr. April Smith-Hirak, the Regional Health Administrator for Region 2 with the Department of Health and Human Services. Dr. Smith-Hirak has been a key leader in the spaces of public health, women and minority health, and infectious diseases for nearly 2 decades, leveraging experience and expertise gained at the Centers for Disease Control to ultimately take on a leadership role within the agency. Dr. Smith-Hirak joins us today to discuss federal health equity priorities, initiatives, and outcomes for the new federal administration. As I said earlier, we will have time for question and answers at the end of April's presentation, so please feel free to submit some questions in the chat towards the end of her presentation. Certainly, if we can't get to all of them, we can always send them to her and get back to you with the information that's so important for you to hear. So with that, I welcome April.
Hi, thank you so much. And I'm just going to share my screen with you all. Oh, I have host disabled participant screen sharing.
Oh, we will fix that right away. This is,
So,
we talk about tech equity, we all have something to learn.
technology, you know, we're getting there. So, as we're working on this screen sharing, I can, let's see if this looks like it might work for me. Yeah, here we go. Let me share this and start the slideshow for you all. And I have security alerts that you all get to see. That's the beauty of working for the federal government. So welcome everyone. And as Rebecca introduced, I am the Regional Health Administrator within the Federal Department of Health and Human Services. So this that you're seeing here on your screen is an organization chart. It is a big, messy organization chart, but it's often hard for folks who are not within the Federal Department of Health and Human Services to understand exactly who we are and what we do, because we have so many different arms and things that we do. So when you look up at the top, you'll see that the secretary is at the top here. These boxes in the middle that you see, those are our agencies, or what we call operating divisions. And you may recognize many of them, like the Centers for Medicare and Medicaid Services and the FDA and the CDC. So these are all part of the Federal Department of Health and Human Services. I am seated where you see the red arrow in the Office of the Assistant Secretary for Health. So we also house the Surgeon General, and my job is all things public health. And this is a little bit about our mission and our value system. We believe in health for all, health by all, and health in all. So looking at our mission for the Regional Health Operations Office, we work to increase opportunities to improve health. And we do this all through the lens of health disparities or health equity, which is the point of your whole conference. It's an excellent fit. And our group doesn't do a lot of direct funding. Our operating divisions that you saw earlier, they're the ones who provide most of the direct funding. We are mostly a policy office. And so for the most part, with some exceptions, what we do is we work to connect and convene, working to establish networks and helping to establish federal priorities within our regions and help those federal priorities move along the spectrum of effectiveness. And so this is our map. We're Region 2. Region 2 is New York, New Jersey, Puerto Rico, and the USVI. Don't ask. I have no idea. There are many, many theories about how we got Puerto Rico and the USVI, but we're very happy to have them. So this is a little bit just about our functions and our unifying goals. And we have this pie chart with our 5 areas that we try to work on through our work in the regions. And so we do policy analysis, we identify gaps, and really what we are is we're like the conductors on the superhighway, hopefully superhighway of information going from our headquarters, from the federal government to states and locals and back and forth, so that we are the ones who hopefully are outside of what we call the Beltway in DC. We are tasked with understanding what it is that's happening in our region and with our partners and our stakeholders, and helping for the information to flow back and forth, so that the way that the government can respond to you is more in line with the reality that you're experiencing on the ground. And when we work through these strategic partnerships, you can see that there are many, many, many different types of groups that we work with. And overall, our goal is to identify the people or organizations that need to be involved in any particular effort, that we can work together, plug holes, and figure out how to kind of pull levers that improve health. And so for Region 2, we have several focus areas. Vaccine access has been very big for us. It's been particularly big in COVID-19, but vaccine access more broadly is also important to us. We see a lot of disparities in vaccination rates, and we are trying to address that. An overall health equity priority has been important to us as well, and will continue to be. And not unrelated, environmental health and climate justice. In all of our region, but also especially for our Caribbean portion of the region, we're really beginning to look at Puerto Rico and the USVI as what might be leading indicators for how climate change and climate justice might affect all of us. We're also working in the opioid epidemic on harm reduction and the increase of syringe services programs. So trying to connect people with care and connect people with health and safety measures. And of course, we have large disparities in our region in maternal health outcomes. So we work on maternal and infant health as well as a specific focus area. So what I wanted to do today is to share with you a little bit about the ways in which our new administration, and we're very excited to be in a new administration with our new Assistant Secretary for Health, Dr. Rachel Levine, and our new Surgeon General, who is actually our new old Surgeon General, Vivek Murthy. We're looking at some of the same ways and some new ways to kind of determine how best to address equity. And when we speak about equity, what I love about your organization is that it's called the health and welfare. And this is something that we have really been acknowledging more in this administration, is that health is not just determined by physical health or by accessing healthcare. It's determined by a lot of environmental factors and factors that are sometimes outside of the range and scope of what we traditionally deal with in public health. So we're trying to be a little bit more inclusive. And so one thing I wanted to produce to you or share with you is this pair of ACEs model. And many of you have probably heard of ACEs. Hopefully you've heard of both types of ACEs. So here we have this chart, and it's the pair of ACEs. Most of you have probably heard of adverse childhood experiences. If you're working in health or welfare, what you already know is that these adverse childhood experiences that are at the top of this tree, like depression, substance abuse, divorce, all of these, incarceration, homeless, violence, experiencing these at a young age and experiencing more of these leads to worse health outcomes and worse outcomes in general. So of course we want to try to limit any exposure to ACEs, adverse childhood experiences. What's a little bit newer in thinking and wasn't always there, but I really like to share this particular image from this article from 2017, is the adverse community events. So those are things like poverty and discrimination and lack of economic opportunity, violence. All of these have effects as well. And when you look at this model, what we see above ground are the divorce and the mental illness and the incarceration and the homelessness. That's the tree and the branches and the leaves. And what we don't always think about are the roots that that tree is growing into, the roots in the soil. And those are the adverse community environments that we really need to be able to address in order to start minimizing those adverse childhood experiences. So this has been around. It's not brand new. This is something that was published in 2017, obviously. So we're in the middle of 2021. But it's not been illustrated or focused on maybe as much as it could have been in previous administrations. And as we're moving our thinking forward and our strategies forward to address equities and inequities, this is really, really important for us to keep in mind, because we can't just address maternal depression if we don't acknowledge the community environment that is maybe contributing to that maternal depression. It's like treating a symptom without treating the cause. So another tool that we have in our toolbox of perspective taking is this CDC ATSDR Social Vulnerability Index. And you might be hearing more about this. And you may even, if you're an organization that applies for grants or who is working with the federal government, particularly CDC, you might see what they call SVI. And I'm going to go over a little bit with you about what this SVI tool is, how it was developed, what it takes into account, and where we have started to see it applied. And the interesting thing about the Social Vulnerability Index is that it came out of ATSDR, out of their geospatial research analysis and services program. So this is like a GIS system, if you're familiar with GIS, where you can do geographical mapping based on different data points. And this was initially developed to help in emergency response. So ATSDR is the Agency for Toxic Substances and Disease Registry, and they deal with things like Superfund sites and brownfields where there have been environmental contaminants. And they wanted a way to account for, in an emergency, in some kind of an event, or a hazardous spill, whatever, how can we predict how that community will respond and what type of support they will need? So that was the impetus for developing this SVI. And they use census tract data, which is important because census tract data is in some areas of the country is really, really useful. It's probably pretty useful in Long Island. It's not as useful in places like the VI because our census tract is so small there. But where it has utility, it ranks each tract on 15 different social factors. So this is kind of looking at those ACEs and those social determinants of health, as we call them. And so there's 4 themes, which in all those 15 factors are existing. One is a socioeconomic status theme, a household composition. So if we're looking at households that are overcrowded, that have many, many members versus smaller number of households, that's going to factor in, especially when you think about how this was created to look at how we would respond in an emergency. Race, ethnicity, and language. If you are with a population that speaks a particular language and has low English literacy, then that will impact the way that you would respond. And also access to housing and transportation and what the quality of housing and transportation is. So those are the themes that go into the SVI data. And when CDC uses these SVI databases and the maps, they can do things specifically where it relates to response. So like estimating how much food and water we'll need because we know how many people we have and how many emergency personnel are going to be needed and how might we evacuate people and do they have vehicles and what methodology do we need to use. And then the last bullet is kind of the important one, especially as we're considering COVID-19 as an emergency. And COVID-19 has been the first point that SVI has been used for a response that was more in the public health or health area than in like an emergency response for, say, a hurricane or a toxic spill. So this is the first time that we're starting to see that intersection between this SVI index that was really developed for an emergency response and how do we set up shelters and things like that, which has a tremendous utility. But what we've realized is also that SVI also has some incredible ability to map out where we have this social vulnerability or negative or positive social determinants of health. And so what we've seen with COVID is that we're starting to look at SVI maps in a different way. And how can we use SVI data to increase equity? And that's really where we're starting to go with this. So you will probably be hearing more about SVI. Now you know that stands for Social Vulnerability Index. And if you see an SVI map, it will look like a shaded map in a particular area, and it'll have funny, weird blocks. And that's not because it's pixelated, it's because it's done by census tract, and usually those census tracts are kind of square or rectangular. But you will hopefully recognize that SVI, and if it's ever asked for, if you're applying for a grant or if somebody is talking about, oh, well, you know, what does the social vulnerability index in your area look like, you'll be able to answer. So this is where you can find a little bit more information about SVI if you're interested in learning more. And this group in ATSDR has some tremendous data analysis capabilities, and we're really excited to see what they come up with and how they continue to use this. And we're really excited to take something that was initially designed really just to figure out how we put shelters in and how we do evacuations as a tool for increasing our equity in our efforts. The next point that we have within the federal government and the Department of Health and Human Services is this class services, their class standards. And you'll see, think cultural health. CLASS stands for culturally and linguistically appropriate services. And these class standards have been around since, I believe, 2013. So especially if you are in the provision of healthcare or health services, you may have already heard about this. And apologies if this is a repeat of things you already know, but sometimes it's always good to have a refresher. And if that's a refresher for you. I hope it's useful. The class standards are a set of 15 action steps, and you can see here that they have a threefold purpose. One is basically to advance health equity. Two is to improve the quality of services, and three is to help eliminate disparities. So there is a principal standard, and then there are sections of standards. And the principal standards is to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices. So there's also a piece here that says preferred languages, health literacy, and other communication needs. This is really key for many of us who are working with communities for whom English is not their preferred language of communication. And the class standards, one of the key things we've noticed in our region is this particular impetus around preferred languages and health literacy, and helping people to understand and feel comfortable as they access care is really key to internalizing and creating more equitable outcomes. So the first area outside of that principal area is governance, leadership, and workforce. And you can see here, and you'll see they're like labeled 2, 3, and 4. You'll see the labels as we go down. There will be 15 of them. But advancing and sustaining organizational governance and leadership, promoting class and health equity through policy, practices, and resources, recruiting, promoting, and supporting culturally, linguistically diverse governance and leadership, and the workforce that are responsible for the service to the population. So we want to work towards having our providers reflect our communities, and educating and train governance, leadership, and workforce in culturally and linguistically appropriate policies and practices on an ongoing basis. And part of that is just being sensitive sometimes to, if you're in healthcare provision and you have a patient, or if you're in some kind of a welfare service situation and you have a client and they need a different language, or they have a cultural basis for their practices, being respectful of and integrating that into the way that you provide services. So communication and language assistance is really big. We offer language assistance and language interpretation. I know that New York State and many of the counties also have tremendous capacity for language assistance and translation services. We try in everything that we do to make sure that whatever the population is, even if it requires a phone call to a translation service, that we have access to those languages. Sometimes even if somebody can understand and communicate in English, it's not how they're most comfortable. And if we're asking people to make decisions about their welfare or their health, it's important that we help them to make those decisions and understand them in the language and in the cultural aspect in which they're most comfortable. So you'll see here, number 8, providing easy to understand print and multimedia materials. Sometimes this is not even about providing materials in another language, but maybe not printing materials at a 12th grade level, maybe printing them at a 3rd, 4th, or 5th grade reading level, so they're more accessible. Engagement, continuous improvement, and accountability. Establishing culturally and linguistically appropriate goals and policies and accountability. Conducting ongoing assessments of how you're doing with the class-related activities and continuously improving those. Collecting and maintaining accurate demographic data, and that's something that we're working on as an administration. The required demographic data from the federal government is not always as nuanced as we would like to be able to access and provide appropriate care for different communities. And so some of the thinkings on definitions and the levels of data, and even down to, I've heard in some instances, the federal requirements say you have to be able to check a box for ethnicity or race, but you can't check more than one box, and that can be a big problem with our communities. And then you're forced to choose, well, which of your backgrounds do you most identify with, but it may not necessarily be representative. And so it's important to us to continue, even as a federal government, to adhere to our own class standards and to really rethink and constantly examine and improve the ways in which we collect data or mandate data collection, so that we're able to design appropriate services. And then, of course, conducting regular assessments of community health assets and the needs, and understanding where we have needs and gaps, and then trying to fill those. And this is the second slide for this, and partnering with the community to design and implement and evaluate policies, which is something that we as an office try to do, something that we as a federal government try to incorporate, and we encourage all of our partner and stakeholder organizations to do as well. Policy created in a vacuum is very rarely policy that's super helpful. It is always important to hear from our constituents and our stakeholders, how that proposed policy or what it is that needs to be changed in order for things to work effectively. And then creating conflict and grievance resolution processes that are culturally and linguistically appropriate and easy to identify. And communicating your organization's progress and implementing and sustaining class to all stakeholders. So we have done class trainings in any number of environments with any number of organizations. We've done it working with incorporating class standards into maternal care and maternal health. We've worked with community health workers and implementation of class standards and how community health workers can help to adapt programming to meet class standards. We are always looking for new ways to train and improve and help people to access and adopt class standards. So if your organization is one that would like either a little bit of help or some consultation, we do have minority health staff who are very happy to create those trainings and to provide assistance when it comes to class standards. And if you want to learn more on your own, here's a couple of websites, and you can see a screenshot of what the Think Cultural Health entry page looks like, and the Minority Health website as well. So I am checking time. We're doing okay. I'm going to talk a little bit about COVID-19 vaccine equity status and vaccine Q&As. And I'm not going to spend a ton of time on these. One, because I want to show you this slide. This is amazing. And for all of you, whether you're a healthcare provider or a community member or an organization leader, for all of you who contributed to making this number happen today, that is amazing. We have a goal in the federal government. As you may know, President Biden wants us all to be 70% vaccinated by the 4th of July. And if you look here at this total where you see the red circle for Long Island overall, 81% vaccinated for adults over the age of 18. And if you look at Nassau, you're 75%, you're already 5% over where we were hoping to be by July 4th. And Suffolk, you're at around 87%, which is amazing. We see 87% in vaccines that we've had out 10, 15, 20 years and have illegal mandates to have. So I know that as community members and organizations and stakeholders and providers, you've really embraced already, and your communities have already embraced COVID-19 vaccination as a key tool for us to end the epidemic and to be able to move forward with normal life. So I do not want to belabor the points that are in the next few slides. If, however, you are working with a small pocket of the community that might be hesitant, I do want you to have this information. So a lot of what we're hearing is that vaccine hesitant stakeholders are actually not always vaccine resistant or anti-vax. They're a lot of times people who don't have access or don't have a trusted source or resource for their questions. And so if you happen to be somebody who is a trusted source and you would like to have a little bit of this ammo in your pocket, then here you are. The vaccines that are on the market now follow the exact same phases of clinical trials, because one of the concerns that we hear often is this thing was developed so quickly, there's no way that it could be safe. I don't trust it. And so one thing that you can share with people who say that is that the clinical trials process was gone through in the exact same way that we had phase 1, phase 2, phase 3, and phase 4. Phase 4 is the vaccine being approved, and they're in the application process for the final approval. We have an emergency use authorization right now on all of these, but all of the safety checks and all of the studies to make sure that this vaccine was being developed properly and was safe and effective, those have all been done. So if you look at some of the safety and the ways that we, with any vaccine, put safety measures and precautions in, you will see that all of these have been followed with COVID-19 vaccines. It's the exact same standards. We have the same vaccines and related biological products advisory committee reviews for FDA for all of the emergency use authorizations. The ACIP, the Advisory Committee on Immunization Practices, considers the same safety and efficacy data before they recommend use. They're independent committees. This is not just the federal government saying, oh, we think it's safe, you should just do this. We actually involve community members who are experts, and we have them do a very critical review. They take their responsibility incredibly seriously. Those meetings are open to the public. They're not safe. They're not secret meetings where you go behind a closed door. They were broadcast. Public can submit questions. And they can listen in and they can see the votes happening and they can hear all of the concerns that are raised and how they're addressed. And then beyond that, the FDA and CDC are monitoring vaccine safety and side effects once the vaccines are in use. So one of the questions we see is, can COVID-19 vaccine make me sick with COVID-19? And the answer is no, because the vaccines do not contain a live virus. They contain particles of the virus. And there's different ways that we get those particles, but none of them are live, so they can't cause COVID-19. Although they can cause some side effects when your immune system reacts to the vaccine, and that actually is just because the vaccine is working and building your immune system. Now, it does take a few weeks for the vaccine to take effect. And if you are exposed to COVID-19 after you're vaccinated before you have antibodies, you can still get sick with COVID-19. And that's why when we talk about precautions and measures that we ask people to wait until they're fully vaccinated, which we define as 2 weeks after their last shot, whether it's a single shot or a double shot series, to make sure that they have time to build that immunity before they, drop their mask, go into workplaces or indoor situations without masks and so on and so forth. So after you get COVID-19 vaccine, will you test positive for COVID-19 if you get a PCR test? No, you will not. However, if you get an antibody test, we hope that you will test positive for an antibody test. That won't mean that you've had a natural infection. It could mean that you've had a natural infection, but it may also just mean that you have antibodies to COVID-19 from vaccination. If you've already had COVID-19, you recovered, do you need to be vaccinated? That's a common question. Frankly, I had COVID-19. I was fully vaccinated, 2 shots. And one of the cool things is that, first of all, we tell people we don't know how long the immunity lasts, and there have been cases of reinfection after a period of time after natural infection. One of the really cool things that we're seeing is when the studies come out is that people who have had previous natural infection and then get vaccinated for COVID-19 are about 3.4 times better at neutralizing the variant strains that we're seeing. So you're actually, I tell people that I'm superhuman now. I can neutralize more variants because I had COVID-19 and then had the vaccine. So if anybody that is concerned about that or thinks that maybe they don't need it, they actually do need to get the vaccine still. It will continue to provide protection. And it seems to actually be a really good combination between if you happen to have unfortunately had a natural infection and recovered, and then you get the vaccine, it actually provides even additional protection. So it's great for that as well. If you were treated for COVID-19 with monoclonal antibodies, you do need to wait 90 days. Otherwise, you're fine. Will COVID-19 vaccine alter my DNA? And the answer is no, absolutely not. Even if you have what's called an mRNA vaccine, that mRNA vaccine is messenger RNA. It never enters the nucleus of a cell where your DNA is stored. There is no way for it to alter your DNA. And so this is just a little bit about how mRNA vaccines work. And if I think you guys are going to share the slides. When you get these slides, if you see this hyperlink here, there's a really cool little one pager of how mRNA vaccines work, and it's a great graphic and it's very easy to understand. So if you're looking for more information about that or want to share that, that is where you would look. Now, viral vector vaccines, which is like the Johnson & Johnson Janssen COVID-19 vaccine, those are viral vector, and it's a different way of producing a vaccine. They are still harmless. They still don't change DNA. They still don't get you sick. It's not live virus. It's just a different way of sourcing that viral material and creating the vaccine. So if you want to have a baby one day, is it safe for you to get a COVID-19 vaccine? This is something that we heard in communities where people were afraid that they would be sterilized. It was a very ugly rumor. And the fact is, you are 100% okay to get a COVID-19 vaccine if you want to have kids one day. And you can receive a COVID vaccine, and there's the COVID-19 vaccine. There's no evidence that vaccination provides any issues with pregnancy. And in fact, we've seen negative outcomes for moms who have gotten COVID-19 while pregnant. And this is a great way to protect you and the baby if that's something you're considering. So the last thing that I'm going to go over in my presentation is something that's relatively new and began with this administration. We now have regional equity councils. So we have a Region 2 Health and Human Services Equity Council. And I'm going to give you just a little bit of an overview. There was a health equity executive order released by the president. And this is a little snapshot of it. And we have a definition of equity now, which is excellent because we like to all operate from the same page. And this is kind of the impetus behind our HHS Region 2 Equity Council. So what we have is we have principal members. This is made up of all of our equity council members. This is all of our operating divisions, and I made an edit, but it didn't go in. We also have HHS IEA in here, so the internal and external affairs, but these are all of our operating divisions. And our principal members of the council are the core group of regional administrators for each of these organizations within HHS. And we meet every 2 weeks. So this is a little bit about our function. We provide tailored support to HHS's equity work specific to Region 2. So the council is working with internal and external stakeholders to promote the equity considerations in programming and services and work toward eliminating disparities, especially where systemic inequities persist. And so we work across HHS and we identify gaps and share our resources, and we work to change policy and practices that undermine health, equity, social and economic well-being, and we work to elevate programs and services that redress barriers to equal opportunity. So we have identified some focus areas. They are COVID-19 and vaccine confidence, environmental health and climate justice, resource needs in Puerto Rico and the US Virgin Islands, resource needs among our tribal nations, coordination and communication with underserved and marginalized communities. This is how we're structured, and this is where you all come in. So we have our principal members, which are just our HHS regional administrators. And then we have that second circle, which is our jurisdictional representatives, which means representatives from all 4 of our jurisdictions: New York, New Jersey, Puerto Rico, and the USVI. Those are also governmental representatives. They're representatives not just from health, but also from human services, from aging, from mental health. And then beyond that, we have quarterly meetings. We have not yet had our inaugural quarterly meeting, but we will be having quarterly meetings of community representatives. And so that would be the place where we have an opportunity for organizations like yours to come and sit with us, work with us on achieving more equitable practices and better health equity and well-being within our region. So we do hope that you will consider joining us when we have our community partners meeting. And so I'd like to thank you. And here's my contact information. And I'll remind you again, if you or someone you know has not gotten your COVID-19 vaccine and you are able to do so, please do. That's all.
Thank you so much. That was just such a magnificent presentation. And I was, looking in the chat and getting all sorts of text messages throughout your presentation about just how rich it was with information. And I just want to highlight a couple things that you said that I think are so valuable to hear from, our federal government and federal administrations, and particularly your conversation around ACEs and the impact of trauma on people's health and well-being and what that means from an equitable perspective. It's just really great to hear you speak about that. And quite frankly, we think that COVID-19 has been, especially because it's a crisis with no clear endpoint, tremendously traumatic. And we know that developmentally, we're going to be seeing over the trajectory of people's lifetimes what the impact of this is going to be. So I really appreciate you contextualizing some of the conversation in terms of trauma. The other thing I would say, just in response, is it's also really wonderful to hear you talk about what impacts people's health outcomes in terms of the social determinants of health, because the organizations on today's call are all folks who provide those social services and provide for those social determinants. And part of the impetus in having this conference is our very strong belief that technology is the newest social determinant of health. So I want to really thank you for your comments. Just a couple questions. As the administrator for Region 2, you were in the front seat as COVID-19 reached pandemic status here in the United States, and right here in New York. And so we've arguably seen the greatest scope of the pandemic compared to many other regions in the country. 15 months in, what have been the greatest lessons that you and your team have learned?
Well, that's an easy question.
Good.
Wow, I think throughout my career, even when I began at CDC, I remember doing pandemic preparations and exercises for H5N1 when we were worried about the H5N1 bird flu. And going through all of those exercises and working on, what would a pandemic response look like? Will people wear masks? I mean, I remember in 2004 saying, I don't think people are going to wear masks. We're probably going to have some problems with this. The importance of messaging, the importance of consistency. I think that, everyone would acknowledge that we had places where the federal government did really well and places where we had challenges. I think that we have learned a lot from them. In our region, it was very, very hard to see even the way that data was reported when we're talking about technology and data. Because we were so hard hit at the beginning of the pandemic, our death counts and our case fatality ratios looked really, really bad. And I always felt that that was something that sort of disadvantaged us because we were the first ones to have pandemic level infection rates in our communities. And we didn't know a lot about the virus then, and we didn't know how to treat it. And I think that it didn't reflect in the numbers the reality of how heroic our communities were and our healthcare workers were, and how resourceful they were, figuring out how to go to Home Depot and split ventilators so that we could pair people on ventilators if we needed ventilators, and then figuring out that maybe we didn't need ventilators. It's so much of a learning process, and so much of what we know now about COVID-19 and how to treat it and how to prevent it was initiated here in New York. And in New Jersey across the river, but really this northern part of our region just absolutely took the brunt of it. And it taught me how resilient we are. It taught me how inequality can result really, truly in disparate outcomes, how incredibly important the work that we do every day and what we call steady state is. If we have communities who are already in overcrowded housing and don't have access to transportation and don't have access to healthcare and had worse health status to begin with, of course, you overlay a pandemic on that and they're just going to do worse. And so what we've seen is an incredible disadvantaging of those communities, which I think has been heartbreaking and also has helped us to create new strategies and find new and even greater motivation to eliminate those disparities. We don't ever want to see this happen again. So, overall, I think we all experienced it. It was incredibly traumatic. It was probably more traumatic for New York and New Jersey than it was for many in the rest of the country, just because of the nature of when our spikes happened and how we had to deal with it in a very low resource situation. So I'm very proud of the way we came through. I'm very saddened by the number of lives we lost, and I am really motivated to eliminate the disparities that led to the inequitable outcomes from COVID.
Thank you. And I think that's very, very congruent with a lot of what our experience was here on Long Island. As I said in my remarks, we're, the 10th most segregated region in the country. And so we saw disproportionate impact of disease in our communities that are historically under-resourced. And it was devastating. And I think to your point about, feeling pride, it was a remarkable thing to watch not only people innovate in terms of treatment of their neighbors, but also just in terms of kindness towards their neighbors, how people came together and tried to very much support each other, whether it was with, supporting people with meals and dropping off meals when families were sick, or in so many of the other ways that we saw Long Island step up for one another. I think the greatest lesson we've seen is that we need each other, and that my well-being impacts yours and yours impacts mine. So we all do better, quite frankly, when we all do better. And I think that the lesson that we've seen in the healthcare community specifically, that's really important to highlight, is that, running in and vaccinating folks and leaving, and not doing anything to create continuity of care or to change the dynamics that led to just the extraordinary under-resourcing of so many of our communities, that too would be traumatic, particularly for folks who don't have those medical homes, so to speak. Somebody gets a vaccine and has side effects and they don't have somebody to call when they're afraid. That alone is traumatic, let alone making sure we're doing everything we can to increase people's health outcomes and life trajectories across the board. So thank you so much for that. Many of the participants on today's conference are strong community representatives, very committed to the priorities of your Equity Council. Given the work your office has done and has on the horizon with the new federal administration, what are the best ways, you started to mention this, but I'm going to ask it again, what are the best ways for our network to really engage in this work with you in the short term?
Well, we really want to hear from you. I mean, one of the key things that we provide for the federal government as a regional office is this understanding of what is happening in our communities. And, I'm not sitting in your backyard. I don't always know what's happening, what your organization is seeing, where there are frustrations that maybe are easily solved by the federal government, and maybe not easily solved. Maybe they take a lot more work, but where we can find those spaces that we can work with you to maybe resolve some of the frustrations or the issues, and also hear what's going really well, hear where there are best practices. Maybe we might be able to share a best practice. So, for us, any way that we can open that communication, if you have something going on that you want to share, the Health Equity Working Group is a really good forum. We have several other outreach and other opportunities. So we welcome contacts. We have newsletters that go out with a webinar and other types of opportunities, conferences, funding opportunities. We like to try to keep as much as we can the lines of communication open. We're a small staff, but we feel really passionately about listening and hearing and trying to resolve issues when we encounter them.
Excellent. And one of the questions that came through in the chat, you spoke so eloquently about language access and about cultural proficiency in terms of delivery of services. In your Equity Council, what work is being done to address the needs of folks who have various disabilities?
Various disabilities?
Yes.
So our key disabilities operating divisions are twofold. We have our Administration for Community Living, and they address aging and also people with disabilities. So they have programming and funding and work with the disability community. We also have, of course, CMS, we have Medicare, Medicaid, and many people with disabilities will be on Medicare or Medicaid. And so we serve that population that way. We also have the Office of Civil Rights, and they hear, unfortunately, complaints from providers or patients who are not getting access and have disabilities. So for instance, sign language interpretation is one that comes up pretty frequently. And then they also go out and they do education for providers on how to be compliant with federal law for people with disabilities. So those are probably the biggest ones. There's a lot more, but that would be what comes off the top of my head.
That's wonderful. No, and I want to thank you so much for being with us today. To everybody on the conference, I want to let you know we will send out the slides that were shared today, so you'll have access to them. It's just so inspiring and refreshing to hear someone in your position speak with not only such knowledge and commitment, but also such compassion. So thank you so much for joining us today. We are so grateful to be the recipients of your wisdom. Thank you. Thank you. So I am now pleased to introduce remarks from a man who needs no introduction, our majority leader, Senator Schumer, who continues to be a champion for our region and for equity, and has been really a consistent, thoughtful partner to the Health and Welfare Council of Long Island. We worked with him, as many of you know, on a number of initiatives, particularly in the last couple of years, as what has happened at the national and federal scope has impacted our region so dramatically. He's just been a tremendous advocate for our region and for all of us. Senator Schumer is most recently responsible for several key victories, bringing millions of dollars of funding to our region, really truly to improve equity and to improve access to care and quality of life. So I'm very pleased to introduce our majority leader.
Hi, everyone. This is Senator Chuck Schumer, and thank you to the Health and Welfare Council for a chance to share a quick message. And my message is simply this: thank you, thank you, thank you to everyone at the Health and Welfare Council for your life-saving and heroic work. From Rebecca Sannon to everyone else on the team, you are heroes in every sense of the word, and I'm grateful for all you do serving the people of Long Island. You're truly the gold standard of service, excellence, and dedication to the community. Very soon, God willing, COVID-19 pandemic will come to an end as vaccines make their way across the country. But we can't be satisfied with simply going back to the way things were before. The crisis exposed so many injustices that long simmered under the surface. And now that we've seen them in the open, we dare not turn away. It's time to take the painful lessons of last year and lay a new foundation based on fairness and opportunity for all people, not just those who are well off. That's why I fought so hard in the American Rescue Plan for more than $100 billion in dedicated funding to New York. That included billions in funding to help fight against economic inequality, especially funding to expand broadband for our schools and libraries, funding for public transit, expanding the child tax credit to $3,000 for the next year and $3,600 if you have a kid under 6, securing another round of stimulus checks, and so much more. We will keep going the weeks ahead and the months ahead as we work on President Biden's American Jobs Plan. This is a once-in-a-generation opportunity to update our infrastructure so we give tens of millions of Americans the opportunity for a better living by training them for good-paying jobs, and especially by making investments in broadband and other crucial technologies. The bottom line, this crisis made clear we all need to work together to close the economic divides that have held our country back. I'm confident that with your help and your commitment to our community, better, fairer, more prosperous New York is within reach. We've come so far, and it's in large part because of the work of heroes like all of you. Thanks, and stay safe.
Thank you, Senator Schumer. As always, a wonderful partner to Long Island. I'm very excited now that we are ready for our first panel. We are going to have our first panel, and then that will be followed by our keynote speaker. So in our first panel, the topic is the humanity of care, building bridges. We are pleased to welcome experts and leaders who have truly led the charge to seamlessly pivot our service delivery to the most vulnerable members of our community in a time of unprecedented challenges. Our panelists today come from a variety of sectors within healthcare, and we could not be more proud to welcome them to our virtual stage. Today's moderator is Colleen Merlot. She is the president and CEO of the Suffolk County Association for Mental Health and Wellness, and she is a fantastic member of the Health and Welfare Council of Long Island's Board of Directors. Colleen has spent the past 20 years leading the region's not-for-profit sector, focusing on domestic violence, mental health, gender equity, and poverty. She's a leader that I personally am proud to call a friend, and I know that label is shared by so many of us here on Long Island. So I turn it over to you, Colleen.
Thank you so much, Rebecca. Appreciate that. So over the past year, technology has played a critical role in our lives in ways we probably couldn't have imagined pre-pandemic. But we've also learned that human connectedness is more important than ever. As we consider technology, we need community-based partnerships and interpersonal connections to build systems of care that are equitable and effective. So for the next 50 minutes, we're going to take a closer look at what we've learned about equity, particularly over the course of the pandemic, and what steps we can take now to ensure humanity stays at the core of our delivery system. I'm going to start by, let's meet our panelists. First up, we have Carice Baz, who is the Acting Director of Whole Person Care at Marin County Health and Human Services. Her focus is on innovation and improvement and advocacy for safety net populations and those who serve them. Up next, we have Zach Hennessy, who's the Vice President of the Neighborhood Health at Public Health Solutions, which is New York City's largest public health nonprofit. Zach focuses on partnering with local communities to improve health, advocate for just policies, secure resources, and leverage strengths to create opportunities for New York City's at-risk populations. Errol Pierre is Senior Vice President of State Programs at Health First, the largest nonprofit health plan in New York State. In this role, he is accountable for growth, profit loss, sales and retention under Medicaid, long-term care, and commercial product portfolios. He also drives initiatives around community affairs and health equity. Frank Miranda was supposed to join us today, but he's not able to be with us. So I just wanted to acknowledge Frank, who's the president and CEO of Hispanic Federation, who will be missed on the panel. So I'm really eager to dive into the discussion around how we can foster and ensure meaningful connections across diverse communities. But let's start by taking a look at the impact. We all know that COVID has affected every single person in every community in some way. Carice, can you speak specifically about the impact that social isolation has had on the communities you work with?
Yes, thank you for the invitation to be part of this panel, and I'm really happy to join you today from Marin County, California. We're a county just north of San Francisco, as you'll see in my Zoom background. And my program mostly works with people experiencing homelessness. And I would just start by saying that the main takeaway is that people experiencing homelessness have been impacted by the social isolation of COVID in the same ways that we have. So all of us on this panel, our cousins and our neighbors, the people we work with, we have all been impacted in a variety of ways by that social isolation, and that extends to people experiencing homelessness as well. In addition, though, people experiencing homelessness have had some additional barriers to their social connection during COVID. In part, it's because of the restriction in their normal gathering spots where service providers formerly had, communal dining rooms or day centers or other places where people gathered. So that is one component of it. But the other component is just think about how we struggled to maintain our social connection this past year and a half. It was largely through phone calls or technology like this, like Zoom. And people experiencing homelessness frequently do have phones. Many of them do have smartphones, but where are you going to charge it if the library's closed? And where are you going to get Wi-Fi to be on that call? And a lot of people experiencing homelessness, their phones work, some days of the month and not others when they're able to put funds on their account, or their phone number may change frequently because their possessions aren't able to be kept safe. And these challenges make it really hard for them to stay connected with each other and with their families and with their care providers and with those who are trying to serve them overall.
Thank you, Carice. That's a wonderful example that people may not call to mind immediately in terms of some of the inequities that we've seen across populations. Errol, what are you seeing?
Sure. So as you mentioned, being one of the largest nonprofit plans in the state, we have over 22,000 members that actually have an aid in the home to help them with what we call activities of daily living. So this is simple things like washing dishes, cleaning, things that a senior would need to just live their daily life in longevity and quality. And when the onslaught of the pandemic happened, a couple of things occurred. Aides were nervous to be out and about, obviously. They were one of the last on the list to be given PPE or to have access to COVID testing. So they were sort of facing barriers to go into the home. And then subsequently, the elderly patients were nervous about letting them in because they knew that the aides had multiple clients and were saying, you can come into my home, but I don't want you going into other people's homes because I don't know if you have COVID. And so what that led to is a senior population that's already vulnerable, not having the person that's close to them, that's culturally relevant, culturally competent, speaks in their own language, knows them by their name, makes them feel a sense of security in their own home, not be there. And so the aid was disproportionately impacted because they were now losing their $15 an hour, which is barely a living wage, right? And then the senior population was also impacted because that one person that they get to speak to in their own home in a safe and comforting way wasn't coming into their home. So we had to act. Obviously, not everyone has access to cell phones, but that was pretty much our only way of being connected to these patients to make sure they had some semblance of connection to the outside world when they were inside these homes. And you can only imagine, how do you go food shopping without your aide if you live in a 5th floor walk up? So we had to figure out ways to combat food insecurity. If you need chronic medication, right, and a pharmacy doesn't deliver, how do you get your medication? So there was so many ways we had to use technology to support equity, which is why I love the forum Techquity, to make sure that during this isolation, people were still getting the care they needed, especially the ones with chronic disease. And it goes without saying, having social contact is a social determinant of health. And someone just knowing that they can call someone and speak goes such a long way. We actually have a nonprofit called Time Bank, which is 3,000 volunteers that actually made a lot of these calls to seniors just to touch base in their own language, culturally competent way, sometimes just to pray, whether they're Muslim, Jewish, Christian, and just to make them feel some sense of family.
Thank you, Errol. That's such an important point. The power of just what seems like a simple phone call, the impact that it can make. And I really appreciate the example you gave, because I think it shows not only the effects COVID had on the system of care, right, when we talked about the healthcare workers, but also on those that we were trying to provide care to, and just the snowball effects of things when it came to poverty, when it came to food insecurity, when it came to medication access. So, there's been a lot of discussion on both the challenges and the opportunities to delivering services during the pandemic. And we've already heard some of the unique ways that we've addressed some of the problems. But Zach, would you highlight some of the strategies that you found successful in breaking down barriers and in building bridges to connect families? And in particular, if any of those strategies changed or were grown from the course of the last 16 months?
Sure. Thanks for that question, Colleen, and it's great to be here. Public Health Solutions is a direct service provider across the 5 boroughs of New York City. So we serve 105,000 primarily low-income New Yorkers per year, providing health insurance and sexual and reproductive health care, maternal and child health, and other access to other benefits, food and nutrition services as well. But we're also a contracting and management services organization for more than 200 community-based organizations and healthcare partners, where we do contracting for complex public health initiatives with both government and philanthropy. So we operate sort of on 2 different levels, both as a service provider directly with very diverse families across the city, but also with a broad range of community-based organizations. So, but it's the people and the human connections. My bottom line up front is that it's the people and human connections that drive and power this work, even when we start to talk about some of the technological innovations. And that's what makes these innovations effective. And that's what we see in the data. PHS has a number of projects that aim to connect healthcare patients and managed care members to community-based resources and supports. through community resource networks using technology. And several of these networks were funded and running prior to the pandemic. But during the pandemic, we greatly expanded our use of technology, including expanding these community resource networks to send and receive referrals across sectors, creating a find services portal where people could access services directly themselves, and using a text SMS chatbot tools for mass outreach and engagement. We were a part of the New York City's COVID-19 Rapid Response Coalition, which brought together community-based organizations, healthcare systems, managed care, government partners, the healthcare associations to respond and try to implement rapidly transformation of service delivery to get people what they needed where they were. To try to understand what strategies resulted in reliable and trustworthy pathways across sectors, we conducted some rapid cycle research with support from the Robert Wood Johnson Foundation, Aligning Systems for Health. And this grant was awarded just before the pandemic. So we were able to look at the partnerships between healthcare and community, both before and then during COVID, to get an understanding of which connections were resilient when co-location, meaning like the community partner and the health system or managed care company couldn't be physically located together anymore. All projects that were involved in this were funded the community-based organizations. That's an important point. And all used a technology platform for making referrals. And what we found was that the projects that were collaboratively designed with clear role definitions and joint decision-making about eligibility and workflows were the projects that were sustained during COVID. And this was in contrast to projects that were relied only on healthcare stakeholder-driven checklists or pure eligibility criteria for referral. And so what we took away was that there are no shortcuts to building pathways across sectors that you can trust. Trust on the healthcare side that the community resource will meet the patient or member's need so that the positive relationship with healthcare providers can be sustained, and trust on the community-based organization side that they will receive people who are eligible for their services, and those services will be paid for and fit within the scope of what the community-based organization does. So we're working, continue to work with this coalition, Rapid Response Coalition, now to shift to advancing some of these strategies at the policy and advocacy level, and really pushing to lift up these learnings and make sure that what we found during the pandemic about what was sustainable and not when it came to technology is what we build into the future.
Thank you so much, Zach. You know, I'm hearing we need to break down silos more and build trust. And that's something that HWCLI is working on through the projects that we've undertaken. But certainly that trust piece has been one of those factors that has been discussed time and again, because without that as a basis, you really, no matter what platform you have or what workflows you put in place, they're going to break down over time. So it's really taking that time to build that trust up front. Okay, the next one I'm going to direct to you, Errol. From your perspective, what are the structural challenges that are preventing us from serving communities?
Yeah, it's a great question. Do you have a couple hours? But I'll touch on some items. So I think for me, this is me personally, when we say systemic racism or systemic bias, it becomes an esoteric term that's really hard for people to understand what it is, because they're like, well, I'm not racist. And it doesn't mean that an individual person has racism or bias, but that the system is producing results that disproportionately impact folks. So I like to strive to say, let's shoot for systemic equity rather than talk about what we don't want, let's talk about what we want. Or even for today's discussion, systemic Techquity. And so the divides are really found around social determinants of health, which is a buzzword, a lot of cliche, but I'd like to use specific examples. So just think about testing. When COVID first came to America back in early February, late January, to get a COVID test, you had to be 65, you had to travel from out of the country for 14 days, and you had to have been exposed to someone who was positive. So guess what that did to our Uber drivers and our Lyft drivers that are disproportionately immigrant populations of people of color that have health first insurance. They weren't eligible to get a COVID test, but they were the ones picking up these passengers from LaGuardia and from JFK. And when they found out they had symptoms, maybe 3 or 5 days later, they got tested, they became positive. This is before we had contact tracing. Those Uber and Lyft drivers that were health first members went back into their community and were spreading COVID and didn't even know about it. And it couldn't even get tested because when they said, are you over 65? They said, no. Have you traveled in the past 14 days? They said, no. Do you know anyone who's positive that you've been in contact with? They said, no. So that right there was a systemic bias that led to structural ways that perpetuate disparities. And so we have to think of how to create systems that reverse that, so that we don't disproportionately impact Black and Brown communities. So that's not systemic equity. So the vaccines then come out. You have to make an appointment. You need to go online. The websites were in English only, and you needed to answer a questionnaire that had like 25 detailed questions at a 12th grade reading level. That's not systemic equity. So we had to have our call centers book appointments on behalf of our members because people with a PhD couldn't book an appointment. So how do you expect someone, with less education to? It was literally built to get the results that it wanted. So we knew where the concentration of COVID cases were. It was in neighborhoods like mine. I'm in Soundview in the Bronx. Yet we did not have a vehicle for that community to get a vaccination appointment the way they get it. We were asking them to do something that's not how they operate. And then we sort of got upset with how people from outside of the city were getting vaccinations, but they were using a system that was built for them. So that's why it's all about the system and how you build it. And then the last thing I'll just say is, there's infrastructure conversations going on in Washington. That could mean broadband for suburban and rural parts of New York. We have Medicaid members in Suffolk County that don't have internet, right? Or in Sullivan County, upstate New York, that don't have internet. And at this point, to me, everyone deserves a cell phone. So think about how everyone has a free mailbox and you don't have to pay money to receive mail. It comes free. Well, the cell phone is technically the new United States Postal Service with email. So to me, it would be, if everyone has a mailbox, everyone needs a cell phone. And so we're thinking of collaborative ways to sort of overcome the digital divide so that we can get our members access to internet so that we can talk to them in a different way to make them healthier.
Thanks so much, Errol. And I love the term in terms of thinking about what you want rather than talking about the negative perspectives and naming things for the problems, but thinking about how can we build systemic equity. So we're going to continue to use that language. Carice, can you talk a little bit from your perspective about some of the structural challenges you see?
Yes, I'd be glad to. Thank you. Well, I mentioned some of the challenges that people experiencing homelessness encountered during COVID just a moment ago, and really those challenges are deeply related to stating the obvious: housing, lack of a place to live. In California, people experiencing homelessness are much, much more likely to be unsheltered than they are in most of the country. So I don't know how much your viewers here today are familiar with just the vast number of people who are completely unsheltered in our region. And this has so many impacts to people's everything from hygiene to technology to sense of well-being and safety and psychological ability to develop coping skills or enhance coping skills that people had. So housing, I think, is the elephant in the room for the community that we serve. And Marin County is a county that is extremely expensive. There's a very high cost of living. And this is part of why the homelessness situation is so dire. It is directly related to the availability of affordable apartments on the market. And the structures of history around redlining and practices of that even exist to some degree today around communities' willingness or unwillingness to embrace affordable housing or embrace new developments for people experiencing homelessness. Those all have an impact on the availability of housing resources. So that the first thing I just wanted to say is housing. The next thing I'll mention is the ability to share information. And this is a really tricky one because we want to be able to respect people's autonomy and privacy and confidentiality, and it's difficult to serve them when we don't have consent to share among all the partners that we would want to share with. And this came up for us somewhat during COVID, but it also is a key factor in the work that I do. In Marin County, we have a universal release of information that covers over 45 participating entities. So these are governmental, community-based organizations, healthcare partners, and others. And that is part of how we are able to do the whole person care. Part of what we do is by collaborating between agencies, kind of like Zach mentioned. However, the Marin is unusual in having that extent of ability to share information. We had a very supportive compliance and privacy officer when our program started, and we do collect explicit consent from clients, and there have been some provisions in California law that changed to support the whole person care pilot statewide. However, we still encounter challenges in coordinating people's care due to information sharing restrictions, especially when it comes to substance use and behavioral health. So I think many of you on this call will be familiar with those challenges, but I just have to name that is a structural challenge. The one more thing I want to mention that I find interesting, back to housing again, the coordinated entry system that prioritizes people for housing based on vulnerability. And then in Marin County, what we do is because we're not developing new housing developments, we pair a housing voucher that's set aside for someone in coordinated entry with really high touch case management so that we can create permanent supportive housing out of apartments in the community. And so this coordinated entry process is constantly trying to prioritize people in a way that is fair and equal and accurately determines who is most vulnerable. And this is a really frustrating and imperfect science. And I had the opportunity to help support our vaccination effort at the planning level in a collaboration between our major healthcare partners and county public health. And I really saw the parallels when the vaccine was just coming to the broader community. That group spent a huge amount of time adjudicating prioritization and who is most vulnerable and who needs the vaccine first. And of course, that is sensible and required. But the minute the vaccine was available in larger quantities, all that work just fell away. And everyone, once you knew that everyone pretty much who needed it could get it within a few weeks, the game changed. And I'm just waiting for the day that happens with our housing work.
Carice, I can see our panelists. I can't see the rest of the audience, but I see our panelists shaking their heads as you're speaking. And I know that the rest of our audience is as well, because certainly the things that you brought up, around housing and around sharing of information are barriers that we face as well here on Long Island. So I'm sure everyone's nodding in agreement and wanting to hear more about how you overcame some of those barriers or are working towards that. So as we look to build systems that are better and more responsive, what have you learned about technology and what are some of the things that we're going to need to take into the future? I think we've spoken about some of them. Certainly access is one of the key ingredients as we look towards the future. Zach, I'm going to turn that over to you.
Thanks. So I think one of the big things we learned is that use of technology needs to bridge the digital divide. That is, it's great to create digital access or electronic access to things through new technologies, but there's going to be a whole lot of people that can't or won't necessarily utilize those. So you need a plan when you're deploying technology to address both sides of the digital divide, and especially concerning with some of what we saw as we transformed our services to remote issuance of benefits and serving people by phone or video chat as opposed to in person. When you have, when you're serving like the aging, the blind and disabled, all of that needs to be taken into account when there's a technology rollout. The second is technology can really support coordination, accountability, efficiency, but effective projects start with effective human relationships, shared goals, and clear understanding of roles. So again, that has to come first. There's no substitution for real and meaningful collaboration. The technologies themselves, you always have to remember, are oriented towards meeting the needs of their customer. And in a lot of cases, you know, their investors are banking on a certain customer. And in our case, that's often the healthcare stakeholder, the healthcare customer, whose interests may be narrow in some regards, limited to who they're interested or able to serve, relative to those of the missions of community-based organizations, which are often broader. In the New York market, if a CBO wants to work with all of the largest health systems and managed care companies, they will have to use a ton of different multiple technology platforms that don't communicate with one another. And this really threatens to further fragment and silo the safety net, add to the complexity, and exacerbates the wrong pocket problem where CBOs bear the greatest burden for solving the problem, while the kind of healthcare sector receives most of the value of the investment and the efficiencies because they choose they drive the proprietary conversation. And so, you know, I think that's really what we need to begin solving for. And I'll save it for question 6, but I have some really key recommendations sort of for the policy and what needs to be done at the policy and government level to begin grappling with some of that.
Thanks, Zach. And that's a good tease for our audience. More to come on that. But I do think, you know, when we think about CBOs and the communities that we serve, technology hasn't always been built for us or for the people that that we're providing services to. And oftentimes, I know we spend a tremendous amount of time duplicating our efforts so that we're entering similar data into different databases and platforms, and it's not the best use of time. And I can't wait to hear those solutions. So, you know, Rebecca kicked off this conference talking about the unique time, the critical time we are in history. And I think we do have a moment to pause and reflect and think about the systems and structures that we've built. And some of them certainly were built on principles that, you know, we need to change. But as we imagine what the future is going to look like, what should be our guiding strategies toward a better system of care? Errol, would you like to take this one?
Sure. And my answer is really sort of focused on what I know Health First does best, just because I've seen the examples. But I think where we're trying to get to is where there's aligned incentives between the payer, which is the health insurance plan, and then the physician that's providing the care, and as well as the community-based organization that's seeing the member technically, you know, way more potentially than the physician. So when we think about social determinants of health, we always say, 20% of someone's outcome has to do with their ability to access care, get to the doctor. So health first in stark reality can only really play in that 20% because we're giving them an insurance card so they can access their doctor. But we know we have to be sort of aware and in touch with, as Zach was saying, with the 80%, right? The housing, the education, the food, the disposable income. So I think what I would love to see is Health First currently has a value-based care arrangement where 80% of our revenue is in a value-based plan with up and downside risk, which means after we pay all the claims, if there's any money left over, we're giving it back to the physicians and the hospitals we work with. I would like to see a future where we weave in community-based organizations into that equation so that a physician sees a member, they do a assessment on needs, find out there's food insecurity, has a connection to public health solutions, and there's a referral that occurs. And this is happening in pilots, but I'd like to see it more systemic. And that referral goes to public health solutions. We meet the food need, and there's a tie back to the health plan and to the provider. So we're all wrapping ourselves around the member, because from a health first perspective, if that member doesn't have food, that's going to lead to another avoidable admission. From public health solutions, I don't like the fact that many community-based organizations in New York are scrambling for grant money, and doctors and other plans are pushing people to them. And then when those organizations ask for funds, it's like, well, I don't know. And so there should be a more strategic conversation around the funds coming for Medicaid or Medicare or these vulnerable populations includes a way that we can have a network that includes our community-based organizations. So the doctors know who they're referring to, the payers have connections to those community-based organizations, and literally the members being taken care of 100% versus now it's like 20% over here, and then the 80% of the social determinants of health are happening over there. And then that's where the duplicativeness happens, right? Where sometimes one member can get 5 bags of food and then another member doesn't get any. And we can sort of remove that lumpiness with more cohesion.
Thank you, Errol. I love what came out of your mouth just now. And I think it's so true. Community-based organizations are a safety net, and we provide vital services. And, if you follow a patient's course of care, it's that golden thread. What are the things that are going to keep that person healthy and well and out of the hospital? And oftentimes it's community-based organizations that are having those small impacts that lead to greater overall health. And, we do need to move, in my opinion, towards a system of care that really values the work that community-based organizations are doing. So, amen. All right, so let's talk about some of the other things that we can look towards. We have some people from government, local and state government on this panel, on this conference. So what can we ask of elected officials? What are some of those specific things that they can do to help us best serve our communities? And I think let's start with you, Zach.
Thanks, Colleen. And thank you, Errol, for mentioning our partnership. I think Health First is one of the plans that's really got skin in the game. And so we're working, in tandem together. I hope we can work in tandem on these kind of policy and advocacy to push on some of these policy and advocacy levers that Errol was referencing together as well. First, we really need to modernize the community services safety net. Many people during the pandemic had to choose between their safety and meeting their socioeconomic needs because they had to show up in person or do things in person and have lots of encounters in person, because the benefit system, the government funded programs were outdated and antiquated and had been flat funded for decades. So the government programs did not allow human services providers to purchase the technology that they needed to keep people safe and provide services that in a new way. So part of future resilience will be to invest in modernization of human services delivery. Second, this wrong pocket problem, the government can really play a big part in helping to resolve that by investing what government hopes to save in sort of the Medicaid and Medicare healthcare costs more directly to community-based organizations. As Errol was referencing, there's the value-based levers, but they could also directly invest in some of those upstream things. Health systems and managed care organizations can continue to make the more narrow member-specific or patient-specific quality-focused investments. And that this way, CBOs can continue to be more broadly focused on their broader missions. 3, invest in community information exchange in conjunction with health information exchange. So investing in community information exchange would enable community-based organizations and government funders to be more technology agnostic, less dependent on a single technology platform, greatly reducing the burden on CBOs. So you could imagine if I were a patient and I was in the emergency department and it was recognized that I was unsheltered, that could be flagged in the electronic medical record, transmitted through a community information exchange, and whether I was using NowPow or Unite Us or Aunt Bertha or whatever the case may be, if I were an organization that provided that service, it would pop up as something that I could pick up and act on as an organization, regardless of what proprietary platform I would use. So in that case, the healthcare stakeholders no longer dictate, if you want our patients, you use this system. So the community information exchange really liberates the community-based organizations and allows them to use the platform that best meets their needs and preferences. 4, establish quality and performance standards for for technology companies to participate in health and human services. They're so unregulated. There's a dearth of standards in this sector, making it very difficult for people to judge the efficacy of these technology products. They're also not required to meet any specific technology specs that would enable them to ultimately be interoperable with information exchanges or other key components of the developing infrastructure. And it should be, if you want to be a part of healthcare payment incentives and Medicaid and Medicare and all that as a technology company, your technology system has to meet certain specifications that are going to enable it to grow and develop into the ecosystem in a way that's best for the people. So those are my 4 policy pillars. Anyone who wants to join me, please get in touch.
We can get that done, right? We can get all those done. Carrie, so I'm going to give you the final word here.
All right, well, I'm signing up with Zach on the CIE bandwagon, the Community Information Exchange. So thank you for mentioning that. I want to zoom out a little bit and just say, if you think about government as the way that our society's values are made real in the world, funded and implemented, I think that COVID has provided some interesting examples of places where we could be having community conversations. And I think if you're in the position of lobbying your government, this is what I would advocate. If you work for government, I think you could have an opportunity to play a stakeholder in this, and convener role. If you think about what the COVID showed us about the role of schools, it turns out schools are a way that kids eat and that they maintain good mental health and social connection. That's what schools are doing. And libraries are a way that people get drinking water and use the bathroom and charge their phone. And even the subway, that's where the social workers are. and paramedics. That's who's helping people who are helping people who are having overdose problems. If you think about those, how the pandemic really made clear where we've invested and where these services are being offered, I think it's an opportunity to have a conversation either about resourcing those settings for that job or about finding other places to resource that. So I don't have the answer, but I think that this is an excellent time to be having those conversations in your community. And because these initiatives are really a reflection of a community's values, I think that my recommendation would be that initiatives really have a lot of flexibility. So the whole person care innovation waiver that the state of California is participating in gave a lot of flexibility to each county to how they would implement it. And I think that that is key because each community and each county has a very different political environment. And a lot of these items are really very political. And to be successful, I think government needs to be partnering with community-based organizations, as we've already talked about, but it also needs to be responsive to the values and needs of the community that it's set in. So flexibility is another thing that I would advocate for. So those are my recommendations, basically having those hard conversations about where do we want to see our work set and how do we resource it effectively, and doing that in partnership with the community.
Thank you so much, Carissa. I think flexibility is always key, and sometimes, you know, community-based organizations are on the other end of that. We get told how to provide services, and we do know best how to provide services. We're in the communities. We know what communities are asking for, and we are the people who should be kind of developing and designing some of those programmings. And I really liked the piece that you talked about in terms of providing services, you know, on the subway, social workers on the subways, but really it's about providing services where the people are and where the people would most naturally want to receive those services. And I think moving forward, people are going to demand that more because we've had a taste of kind of a different way to deliver services. So I want to thank all of the panelists today for providing, you know, some ideas about what we can do here in our communities to move forward and take the lessons learned and really apply them in a way that is transformative and that is towards a more equitable future for all of the people that we serve. So thank you all so much.
Thank you. Thank you so much, Colleen. You know, I think that was just an extraordinary panel, and I want to thank you and all of our wonderful panelists. Errol, I will tell you, I am taking that phrase systemic equity and I am using it as we go forward. I've always said, I think it's important to talk about what you stand for and not put your energy on resisting what you don't want. And I think that's a great way from a linguistic perspective to articulate that. And I think it's wonderful. And so thank you for that. And for the story, particularly about the Uber drivers, which I think was just such an interesting and important comment to make. So thanks to all of the panelists. You were all extraordinary. Thank you, Colleen. Next, we are going to introduce our keynote speaker for today's conference, Dr. Nicole Turner-Lee of the Brookings Institution. Dr. Turner-Lee is a nationally recognized expert on the intersection of race, wealth, and technology within the context of civic engagement, criminal justice, and economic development. She will address these issues and more in the context of telehealth, broadband access, the digital divide, and tech equity. Dr. Turner-Lee's most recent publications address biases in machine learning algorithms, the digital divide, 5G mobile infrastructure, and telehealth. She has written extensively on the digital divide in both urban and rural areas and the availability of local health resources, including those enabled through telemedicine. She has a forthcoming book, very exciting, on the topic, Digitally Invisible, How the Internet is Creating the New Underclass. We will have an opportunity for questions and answers at the end of Dr. Turner-Lee's presentation, so please feel free to submit them in the chat box. And I welcome Dr. Nicole Turner-Lee. We may need a minute here. Let me just check.
Rebecca, we're just waiting for Dr. Turnerly to log on. Should
great.
only be a minute or so, and we'll get her on.
Right, so we'll just take a 2-minute break for folks who need to take a bathroom break. You have about 2 minutes while we wait for our keynote. Thank you. Great. So everybody, thank you for bearing with us while we took a quick break. I introduced Dr. Nicole Turner-Lee just a couple minutes ago, and she has now joined us. So Dr. Turner-Lee, we're thrilled to have you, and I'm turning it over to you.
Thank you so much. And welcome to Zoom, everybody. We're trying to figure out all the ways to maneuver through this. Well, I'm so excited to be here. I didn't hear my introduction, but I will be able to tell you a little bit more about myself before I jump into the keynote. I'm Dr. Nicole Turner-Lee. I am a senior fellow at the Brookings Institution here in Washington, D.C. I'm also the director of the Center for Technology Innovation here at the Brookings Institution. In my work, I focus on the intersection between technology, race, and social justice. And I also spend a lot of time on other issues that you commonly hear in the news, digital divide, infrastructure, broadband infrastructure for that matter, privacy, spectrum, China. I do all of that, including artificial intelligence. And I'm really excited about, speaking to you all on this topic because I do have a forthcoming book that will be out later this fall on the US digital divide. It is called Digitally Invisible: How the Internet is Creating the New Underclass. And I would be remiss if I didn't actually share with you one more thing that you all should know. I actually grew up in Long Island, in the great city of Hempstead, in a little community called Malvern, where my grandmother and aunts and uncles lived. I spent a lot of time there with my parents until we moved to Westchester County. So don't hold Westchester County against me, but I am from Long Island, parts of Long Island. And so you may hear that it come out, which is great because I'm speaking to my people. With that being the case, why am I here today? I mean, I think it's no secret based on what we're doing right now is that technology is sort of taking over. It's transformed the way that we live, we learn, we earn, we love. And it's even transformed the way that many of you on this call are really square in the middle of, which is how we deliver healthcare. And at Brookings, we've spent a lot of times talking about healthcare and the intersection with technological tools, especially as we revisit these notions of telehealth or telemedicine, and now the most recent term of digital health. We published a paper a couple of years ago on telehealth. And what's interesting about this is I actually probably have about 15 years of experience in this space. And I'm going to tell you how in a few moments, but I wanted to set this talk up to let you know that technology has really crept into the space where most of us care about, which is how do we actually improve upon the delivery of healthcare services? And more specifically, how do we look at the access to technology as either a barrier or a provider of the type of pathway that people will need to be able to get online and visit and talk with their doctors? I think there's something else that I'm going to address in this talk that I think will be pertinent to everyone as well, which is how do we look at telehealth and the potential leveling of the kinds of health disparities that we see that exist between Latinos, Blacks, tribal members, as well as white Americans? And what can telehealth actually do to sort of stop the bleeding that occurs when we look at not only the provision of healthcare, but the affordability and the access to quality institutions? So let me start this little story so that you understand how I got into this space more than 10 years ago. I know I don't look older than 21, but I am, but I will share the story in the meantime. So many years ago, I do recall working in the city of Chicago. I was finishing my PhD at Northwestern. I, at that time, had married early, and I had a young child who had asthma. We landed up working in a place where a young lady who was similar in age to me at the time, she also had a child who had asthma. I lived on campus in Evanston, Illinois. She lived in the heart of Chicago's South Side. And I went to my primary care physician to actually take care of his asthmatic conditions. He's now 18, go figure, and has grown out of it. My colleague, on the other hand, a single parent as well, landed up driving her mother's car, taking 2 or 3 buses when she could not get into the emergency room to ensure that she was addressing any type of respiratory failure. Fast forward a few years into that job, it was a part-time job while I was in school, my child sort of grew out of it. You know, he was able to wean himself off the prednisone because of the quality of my healthcare insurance, and he now doesn't have any symptoms or signs of asthma. My colleague's son, on the other hand, actually, it became much more at risk of asthmatic failures in terms of whether or not he played sports, if he was walking down the street. She spent a lot of time in the emergency room, more than I had ever imagined. And to this date, her child still has it. And I think they're about the same age. When you think about that scenario, the scenario that I'm sharing, where we have seen low income, disproportionately people of color, as well as those on rural or tribal lands, rely upon their emergency healthcare systems. And this story that I'm sharing, again, is almost 20 years old. Those types of phenomena have not actually been interrupted as we've seen the progression of healthcare. And if we fast forward from that story to where we are today, and we think about where telehealth was prior to the pandemic, I think most of you would actually agree that we've come a long way. I mean, right before the pandemic, and I share that story about that young lady because it actually inspired me to think about at that time, what would happen if we had a virtual clinic in the heart of a public housing development? What would happen if we invested in our community care clinics? What would happen, and I was working in tech at the time, if we actually had the ability to have, and I'm going to be honest, it wasn't the internet that we know today, it was that funny sounding internet that said you got mail. But what would happen if we were able to transmit information in ways that just went beyond the walls of a hospital institution or any type of clinic, where we could actually give secondary, tertiary care to people like my former colleague? Well, fast forward after that, and here we are today, actually digging, drowning, diving into telehealth in ways that we've never imagined. Now, prior to the pandemic, before I get into issues related to digital access, we weren't using telehealth the way that we are now. And why is that? I mean, we, for the last 15 to 20 years, have been dealing with issues related to licensure, reimbursement, parity, whether or not there was any type of certification needed, what qualified under Medicare or Medicaid. And through the stroke of a pen, as the world actually began to realize just how inevitable the consequences were of this pandemic, we actually now see this familiarity with going online to talk with your doctor. And I was telling someone the other day, what's so interesting about this whole movement towards telehealth, it almost reminds me of when we went to electronic records. And I know some of you are probably giggling, because it took a long time to get to the portability of records and files of patients, between patients and doctors, a variety of doctors. And now you go into a doctor's office, and the first thing that they open is not necessarily their lab code to pull out a pen, they pull out a laptop. Well, my friends, when we look at where the state of innovation has come, and the fact that we're now looking at telehealth as one of the pathways towards increasing the opportunity of people to see their doctors in real time or to manage chronic disease, I would say we've come a long way. And I would say we've come a long way in the statistics. We now report, before the pandemic, the numbers of telehealth visits were quite flat. There's been a 100-fold increase in the number of telehealth visits that are actually made per day. Now, what does that mean going forward? Some of you may be familiar, and some of you may not be familiar with the fact that at the end of the year, there's going to be an expiration of those waivers, and that we may potentially see a backtrack on the use of digital services for healthcare, simply because the pandemic is slowly weaning itself out of our lives. But more importantly, we've got to figure out how this is monetized for the betterment of the practitioners and the clinicians. But I will say, in some data that has been released so far, is that we are seeing sort of this movement towards value-based care, which is actually exemplified, I think, in the telehealth movement in ways that we didn't talk about it before. That there might be something to increasing the volume of how many people you can see if you are a doctor by using telehealth, and there may be value in actually being modality neutral so that you have a way to see the patient asynchronous or synchronous. With that, I'm not going to bore you anymore with these telehealth notions, and I hope it was helpful as I actually opened up my talk, but I want to get at the heart of why I share this. Here we are in a society, in a pandemic, where getting online was basically a sign and symbol or recognition of those who had the privilege of having high-speed broadband access. And today, we know, and it's something that we see daily as we think about schools and employment and commerce, that being online is perhaps the only way to benefit from a plethora of services, particularly healthcare. And we have a problem. And this is something that I discovered in my book as I went around the country talking to a variety of community stakeholders, is that not everybody is connected. And that lack of connectedness leads itself towards a digital divide, which is what I think the coalition wants me to talk about today. When you think about the digital divide, some of you may have heard this before it became the public news. As I told somebody the other day, I've been more busy than I've ever been before, which is great because I've been waiting for a time like this. I'm doing this for like 25 years. But what's so important and critical about the digital divide is that it's so much different than prior to the pandemic. Before the pandemic, when we talked about the digital divide, we talked about it in a binary context. Who had access, who didn't, who had an internet connection, who did not. We did not necessarily talk about it related to the types of services that actually run over broadband networks, like telehealth, like education, like employment. Just consider for a moment, in the case of education, the fact that 50 million school-age children were sent home because they could not stay within the classroom. 15 to 16 million of those students did not have either home broadband access or a device. 9 million did not have either. And the majority of that 9 million were Black or brown or low income or rural or tribal populations. And we're now 18 months later, 14 to 15 months later, time is fleeting me, realizing that those kids that did not have access to the internet are now experiencing learning losses by 1 to 2 years, meaning that in about 4 to 5 years, we'll experience what it meant to be disconnected during a time when you could not even learn. And now when we look at health and we think about the fact that this pandemic knew how to prey upon the vulnerabilities of certain populations who are already on the wrong side of health equity. Did you know 70 out of 100,000 Black Americans died of COVID? In fact, the numbers were so startling, one of my colleagues actually wrote about this, that it was not necessarily because of their lack of access to healthcare only, but it was the living conditions or the ability to have trustworthiness in their doctors, as well as their work occupations that contributed not only to their exposure, but in some cases, their inability to find follow-up care. I personally, being from New York, lost about 4 or 5 people when New York became the hotspot state for the virus. And the majority of the Black and brown folks that died from this virus have now left children who are going to grow up because they've not lost one parent, but 2 parents from a disease that knew not just how we weren't as a country taking care of our most vulnerable, but 2, a country did not value healthcare in the way that we wouldn't have these mass health inequities. And so here we are, again, coming out of a pandemic where we finally are seeing lower rates of infection, but going on that same paradigm, my friends, we're seeing less likelihood of communities of color who want to get the vaccine based on historical trust issues that can be related to the Tuskegee experiment when Black men were injected unfairly with the syphilis disease, or my idol, Henrietta Lack, who actually donated her DNA towards the cure of cancer or some advancements in cancer cures, but was never reimbursed and died as a very poor woman, despite her DNA making incredible strides in that disease. I think you know where I'm going when it comes to the fact that we need to start moving forward with a mode of communication and delivery that can be ubiquitous and available to everybody. But we need to do that recognizing that health disparities are not existing by itself anymore. Health disparities sit alongside digital disparities. And unfortunately, if you do not have access in this country or you cannot afford broadband, you're not going to have the same type of quality connections with your healthcare provider. And so what does that look like in the real world if we're not talking about, again, a binary digital divide? What that means, my friends, is we have in this country a broadband deployment and adoption issue. In rural communities right now, and this is something I'd love to share with you all just to kind of put it in frame, prior to the pandemic, we had about 14 to 15 million people who were not online. Those folks that were not online is what I call in my book, the digitally invisible. And they were people whose systemic inequalities of poverty, of racism, of gender inequalities, of age inequalities, of being foreign born or tribal, they literally were not given digital access or didn't have digital access, which in many respects made them part of another America, or what I call the digitally invisible. You couple that with, again, the movement towards everything migrating from analog to digital, you have to say to yourselves as practitioners, what then do we do and what role do we play in closing the divide as much as we play in closing health disparities? So for people who are not online, the biggest challenges that they face is they either live in an area where there's a lack of broadband availability, whether you live in the rural lands of Kentucky, up in the high mountainous terrain of New York, or if you live in areas that might be more urban or suburban, but because of the cost of service, you're unable to afford it or there's lack of competition, that presents barriers to the adoption of telehealth. And so one thing we do have to address, and you may be watching this with President Biden, is that we have to look at broadband as a critical infrastructure. The other thing that we find when it comes to broadband access is that people don't just need the access, but they need a device. The Pew Research Center just actually published a great finding that we are now seeing a higher percentage point of low income and vulnerable populations that are now getting online. Those numbers may seem very insignificant to you. It's like a 0.13 range for Black Americans, a 0.12 range for Latin Americans, but those are significant because the people who are not connected right now, those digitally invisible people, are the ones that we have to worry about the most. They are like my colleague with the child with asthma, who would have never imagined, well, back then we didn't have the internet the way we know it now, but would have never imagined the power of being remote to take contact with her doctor, her son's doctor, on a regular basis to avoid the chronic nature of the asthmatic condition in which he had. I hope you're staying with me because, again, I tell people, I'm like a Black Baptist preacher. Don't get me started. I know I'm going to stay in time, Lori, but I want to be clear that you cannot solve health disparities without solving digital disparities, particularly as the healthcare industry and healthcare provision, whether it's community-based or institutionally based, as they actually rely upon technology to get things done and to provide services to patients. Another thing we have to worry about is affordability. So we're working on a paper right now at Brookings, which has a lot to do with the digital health. And we're looking at this perspective from the standpoint that we now have all of these new devices, cardiometers and sensors and Fitbits, et cetera. But those tools, which often assist in the management of an either chronic condition or preventative, are not always available to the poor. And when we think about, again, going back to some of the health concerns that we now have in terms of the long-term effects of COVID-19, we are going to see a marketplace for these types of digital transportable devices that many practitioners are going to want to use, but they will not be able to use it amongst their clients with the highest risk and highest need. One of the things that we're talking about in this new paper coming out is that we need to keep pushing for the type of telehealth provision and regulations that allow for the same type of national experiment that we've had for these last few months. But we also need to make sure that we're being tech neutral and not necessarily picking and choosing modalities. One of the neat things that I just read in a report on telehealth is that we see the skyrocketing of phone contact as well as tablet-based contact. And in some cases, people come back later and actually read the doctor's notes or orders. Friends, for me, if we know, and I'll give you just a stat on this, that people of color, Latina, African Americans primarily over-index in the use of mobile devices, those modalities will be very important in staying in touch with your patients. But more importantly, what we also know is that we've got to figure out, this is something I put in my book, which is pretty radical, how can we engage healthcare providers in a way that in closing the digital divide, perhaps they are reimbursed for some of those digital health tools, or they're able to give their client a tablet, or we're able to allow this intersection between health technology and digital technology from a general purpose sense so that we can keep people healthy, well, alive. I was thinking the other day about this COVID vaccine sign up and the fact that we relied totally on digital for people to actually sign up for vaccinations. And there were hundreds of thousands of missed opportunities because we still were addressing a digital divide concern in this country. How many people weren't able to follow up with those appointments or even get an appointment as a result of that? So we've got to figure out a way to close the divide as we close the same types of disparities that exist on the healthcare side, my friends, so that we can narrow the types of differences that actually come in care and treatment when people are sort of stuck within an analog society. The second thing that I think is important, in addition to having healthcare providers start to take attention and concern over closing the divide, is that we need to focus on making sure telehealth is here to stay. At the end of this year, all of those waivers will be pretty much expired as we start to see legislators and health insurance companies and others sort of backtrack on some of the permissions and the relaxation and regulation that we actually saw. Now, in some respects, we've seen some legislators like Senator Schatz and others who are putting out legislation now saying that we must keep telehealth in the queue, and rightfully so. I think we're starting to see some data from the American Medical Association and others that are suggesting that this actually wasn't a bad idea. But as I was telling colleagues the other day online, that we have to think about the fact that there still has to be discussion on reimbursement models. We argue in the previous paper that we did that parity perhaps was a barrier to the type of innovation that you would see with telehealth. In came the pandemic, which was based on a parity model for reimbursement. We have to make those decisions on whether or not we're going to stay in that mode, or if we're going to incentivize by maybe lowering the cost of telehealth visits so that doctors can increase more volume within their offices. I mean, right now it's available for patients. And that might not be a bad thing, because if we're able to do that, my friends, and maintain telehealth services, I completely think in my heart that we may be able to address some of the health disparities. Congressman Jim Clyburn was on a podcast that we have at Brookings called Tech Tank, and he made no mention of the fact that we need to continue telehealth because in the rural South, we have lots of cases of people who cannot get to a reputable institution, whether it's an academic-based hospital, a larger network of hospitals, and in the absence of a lot of community care clinics, what he was suggesting, we need this mode of healthcare delivery to ensure that people don't go further down the well of health inequities. And I think he's right. And one of the things that he says is we need to go back and really revisit community care. Now, there are some of you, again, going back to my previous remarks, that may agree or may not agree with me, but there's something probably to be said about telehealth and values-based care, but there's also something to be said about really revisiting telehealth in a 2.0 mode, so we're not going back to the same old things. Yes, we have to solve things like licensure, whether or not you can have interstate healthcare delivery, whether or not it's reimbursable. We have to deal with what services are reimbursable. But most importantly, as a mode, it does offer this opportunity to bridge some of those gaps that may exist in communities where they are just very slim when it comes to other critical infrastructure, not only broadband, but water systems or food systems, etc. Now, if we don't encourage Congress, as well as our state and local leaders, to continue telehealth, does that mean that, we'll go back to the same old practices and procedures? Well, I'm going to say this with a straight face. Probably so. And if we don't continue telehealth where it is in the public interest, I can imagine, based on my 20 years of experience watching this, that it will go back to being a privileged utility of those that are wealthy or have health insurance versus those who do not or live in isolated areas. And I'm looking at this chat because I see somebody said from the far eastern part of Long Island, yes, we have to deal with all of this, because what people don't realize, it's not where you live, it's the quality of the institutions or the infrastructure around you that make a difference. And so that isolation on the far eastern part of Long Island, which I have had the opportunity to go to, is the isolation where we want these types of levers available so that people have more choices in how to engage in quality of life decisions. And I would say third, so we've got to deal with the digital divide as part of the health equity conversation. So closing it is a health equity issue. We have to be supportive of the fact that we want to continue telehealth services beyond the scope of the pandemic. And I would say third, we need to think about, if we're addressing equity, how we begin to look at different models in the provision of care. So I'll give you another perfect example, which I found to be very interesting. We know with this vaccination that we have a lot of people who are hesitant, some for political reasons, some for religious reasons, some for cultural efficacy reasons. As I shared previously, Black communities that are very concerned about taking the vaccine simply because of the historical past and legacies of the lack of trustworthiness when it came to government solutions and interventions. With that being the case, what is interesting, if you've noticed, that has happened to sort of accelerate the acceptance of the vaccination is that we've seen faith-based leaders get involved. Churches set up medical clinics where they're actually administering the vaccine. We've actually seen social service agencies play a significant role in part in the awareness raising. We're starting to see trusted ambassadors walk door to door and speak to people about their concerns. Now, I share that because, again, one of the things that we often see in healthcare is sort of this silo that doesn't necessarily integrate the people into the process and create a more participatory model for engagement. And I say to all of you who I know in some way, again, by the nature of this association, care about health equity, as you think about the providers that you engage with, and you think about the grassroots engagement strategies that you are employing, we need to consider that this nation now has a great model, a proof of concept, that all of the things that you've been doing work when it comes to advancing and accelerating care for impoverished communities or vulnerable populations that may be geographically isolated. I say this in all seriousness. For me, in my work, the pandemic has been like this national I told you so on steroids, because there are so many instances where advocates like yourselves and leaders within the healthcare space and people like myself in the policy space who care about vulnerable populations and social justice and equity, we've been trying to say that this is an all hands on deck strategy. And for years, we've been told that it has to be a one size fit all approach in how we actually address these types of inequities. What we are seeing, my friends, which I think is so interesting going forward, if we take on this champion of closing the divide and making sure that we have equal access for all people, regardless of who they are, their age, where they live, how much money they have, and we start to realize this as a civil right, the same way that many of us on this event envision the delivery and the availability of healthcare, quality healthcare as a fundamental right of people, then we've got to start talking about this importance of people who are the everyday laborers getting stuff done. What I most enjoyed about working on my book in this last year is prior to the pandemic, I had the opportunity to actually go out and visit communities. And so I found myself all over the country, from Phoenix, Arizona, to Garrett County, Maryland, to Stanton, Virginia, to Syracuse, New York, Hartford, Connecticut, about 7 or 8 places. And when I was in Phoenix, Arizona, I happened to meet a young lady in the parking lot of a library. I had gone into the library after visiting a school, and I wanted to sort of see what kind of technology setup they had. And a Black woman came up to me and she said, "What are you doing?" And I told her that I was working on a book and I was interested in just sort of seeing the role of the public library in advancing community broadband access. And so we got to talking, because you can tell I'm a pretty friendly person. You know, it happens when you move from the north to the south and you start getting people who are very cordial and courteous to you, that you become that person. And we began to talk, and I told her about the topic I was working on. And the lady turned to me with a smile on her face. And she said, "Miss Nicole, I don't know how you're going to take this, but I got stage 4 cancer." And I don't know about many of you who may have friends or family members who have sort of shared that with you. You don't know whether to say hug them or to say nothing at all. I just, sort of nodded my head and waited for her to respond. And what she shared with me in that story, which I share in the book, and it took my heart, was that thankfully, because of her smartphone, and thankfully because her doctor utilized telehealth to stay in touch with her, because it was sort of at the beginning of the pandemic. It was 2 weeks prior to the pandemic, as a matter of fact. She was able to get in quickly to start treating it. She kind of made this mention as, I didn't know for a long time why I needed access to technology, but now I realize I needed it for this announcement, because I've been coming to the library to make sure my son had access to his homework. And here I am now looking up how to manage my diagnosis and also speaking with my doctor on my cell phone so that I can stay well. And I hope I live, is basically the words that she shared. And I thought about that experience, and I took it to one of my peers that works in the healthcare space. And we began to think about the fact that these new models that many of you are employing, these models that we're seeing in terms of bringing access to low-income people. And this was a woman who was of very minimal means. She had shared with me she had moved to Arizona after going through a horrible divorce and did not know how she was going to make it day to day after living in her car. The real people in America, my friends, their stories are so rich and so full, but yet they give us the disturbing realities that in this country, we've not integrated them into our policy making, nor in how we make decisions to ensure that we close these equity gaps. So I share this as we think about, again, making the digital divide a part of the ecosystem of closing the health equity gaps, ensuring that we continue telehealth. I think the third thing I want to just impress upon all of you as I get closer to close is that we continue to engage participatory models where we can find local trusted ambassadors and stakeholders within the community that also care about health inequity, but more so social inequity, that they can also make the type of pathways and linkages and alliances that help us do a better job in identifying how we treat those that are the least likely to be treated or trustworthy of the healthcare systems in which we have. You know, listen, we're not probably going to get to universal healthcare, at least in my lifetime, maybe in my children's. But one thing that we will get to are people like yourselves who, under the umbrella of this organization, care about health equality. And I'll close with this final point, and I see questions going up and down, so I think it's so important that I'm kind of giving you an aha moment. But I want to close with this last point as I thought about this talk and why it's so important. Now, I'm not necessarily pushing you to just do everything technological, because I think it's important and it has some efficiencies and relevance to the life in which we are in right now. I think it's something that could be a complement to any system that we have, whether it's education, whether it's employment, whether it's civic engagement or healthcare. Technology does not replace these things that we do, my friends. It complements it. It helps us to organize it better. It puts power back into the hands of consumers. And at the same time, it allows us to collect and track data to see where there are trends of when we're doing things right and where we're doing things wrong. That's one of the things that I found so interesting, again, during this pandemic, that we have been so deliberate and so attuned to what the quality of healthcare has been in this country, because we've had to fight the ugly faces of this pandemic. But with that being said, not all technology, as my grandma would say, is useful if you don't know much about it. And so the last thing I would say to all of you, as you think about, you know, bridging the digital divide, you think about the experiences that we're going to have and everything becoming much more digital and mobile, is that we also as practitioners need to consider what could be the ill consequences of a technological tool if designed by people who do not have the lived experiences of the community, but also if done in a way that is sort of placed upon communities in ways that it does not recognize the sensitivities. And I see Clifford put in there about accessibility. It's wholesale where it cannot have the tools that are levers that are needed to ensure that our disability community can actually use this, that it's equally accessible. I'll give you a story, Clifford, on that just real quick. That's why I should close my chat, because I want to be all in you guys' conversation. But I'm thinking about when educational technology, when kids had to go remote, many kids who are autistic had to be sort of disturbing for parents to have all these open links and emails that they actually had to do, but at the same time, they couldn't handle it from the mental capacity. Because guess what? We think that technology can be wholesale. So what I want to end with this on is to say to you, all of you, there are promises of technology and there are perils. And we have to be equally sensitive to the very technologies that we think are going to be put on the wrist of a patient dealing with respiratory trauma that may collect data that will tell us something about that person. And then we make the assumption that they may be smoking too much, not realizing that they may live in environments where they cannot dismiss themselves from a household of smokers or a community where there's just poor environmental remediation. That's a big outlandish discussion, but it's another discussion I got to come back for. But in my work, I always tell people there's always more to the story. And as a sociologist, I always suggest that we need to start looking at these tools as from a socio-technical perspective. And therefore, we can recognize the sociological implications with the technological innovation to make great agency over whether or not we choose to deploy them. My friends, I'm not going to be a Black Baptist preacher, and I'm going to start to close because I want to get to these questions. But I want to say this. This is the greatest time to be in your seats. And it's the greatest time for a couple of reasons. We have a tool that is much more fluid than any tool that we've ever had in terms of getting people into a facility. Much like I shared with that story with my colleague, she had to go to the emergency room to care for her child. She didn't have any other option. And this is a great time for this community as well as others to start impressing upon policymakers that this worked. And if it worked in a way that could be meaningful and ubiquitous and widely available to your patients, and obviously if it works in a way where it's fiscally feasible, let's keep doing it. Let's keep doing it. Because the greatest loss that we can offer citizens of the United States is not just this notion of universal healthcare, but it's this ability to try something different that may minimize inequity or the impact for that person of color, that older American, that person who doesn't speak English as a first language, that rural person. What can we do to leverage the power of the technology that is in our hands, our purses, and our pockets to decrease the type of consequential impacts that the lack of access to quality care has? Can't have any more people dying, folks, just because they had a lack of access to quality care. And so please get my book when it comes out and have me back if you I'd be interested to listen to again. Follow us in Brookings. We're writing a lot about this. I will share with the team the links that we had to our previous telehealth paper and our forthcoming digital health paper, and keep talking about this stuff. I think that the more and more we can get closer to the ground to discuss these issues, the more and more we bring the people to the center versus just the policy. So I'll stop there because I'm seeing the chat go. And as you can tell, I have a lot to say. So I want to make sure I get to some of the questions, Rebecca, before we wrap up.
Absolutely. No. And we have about 15 minutes for questions. I just want to start by saying, first of all, I mean, sometimes I get accused of having a lot of energy. And I feel after listening to you that I must sound like I'm asleep because you are so full of passion and so full of wisdom. And just, I can't thank you enough for just the framing and the context that you provided in sharing the information today and the stories. And again, just the personal commitment, because that's what it's all about. But way before you did that, I know everybody on this call fell in love with you when you said you're a Long Islander.
Yes.
So just for that reason alone, you won the day. So just a couple of really quick comments before we go into questions. We talk a lot about technology being the new social determinant of health. And I think that, it speaks to what you're talking about today. One of the issues that we face on Long Island, in addition to a lot of the things that you talked about in terms of people's occupations and their relationships with their doctor and their opportunities around continual care, is housing. And, housing is really at the crux of a lot of what we saw here regionally when it came to COVID-19. There was a belief that communities of color were overrepresented in positions of essential workers, which is true. However, the other piece of the coin that often was not talked about enough, certainly in the policy realm, was how many people are living in cramped conditions, multiple families in single dwelling units because of lack of affordability, and then what that meant from a quarantine perspective. So. And then the systems that were failing that, right? So someone would go into a hospital with COVID-19 and be stabilized and be able to go home. And nobody would ask the question, can you go home and safely quarantine? And that really was a devastating aspect of this pandemic for us.
Yeah, if I can say real quickly, my colleague Rashawn Ray has written a lot about this when it came to just how disproportionately affected poor communities were by the pandemic. Particularly the housing thing was real, right? And if you even look at that from the educational sense, prior to our ability to get a handle on this pandemic, we actually saw kids who were poor, rural, Black or brown, actually have a higher susceptibility to the virus as well, which is why a lot of parents opted not to have them back in school. Because if they were frontline workers, some of the research is suggesting that they wanted their kids home because the likelihood of a child getting sick, passing that on to a frontline worker whose job security was also, very vulnerable in a home that's cramped, is a problem. And I think, again, I tell people this pandemic sort of gave us an opportunity to sort of look in the mirror. And the question is, will we look in the mirror to see ourselves slimmer or we will see ourselves with flaws? And I think that's something that the White House has sort of been struggling with, but we as policymakers too, because the issues are so vast. So I'm glad you brought that up because I think that to me was even as a Black parent myself, it was a huge concern in terms of the type of susceptibility based on the type of work people in my family, extended family, were doing and the extent to which we could keep people safe. And then I'll just say this too, Rebecca, the statistics also telling us because of the lack of quality health care or chronic disease maintenance, we had a lot of families who were poor, who lived in cramped conditions, who had a set of their own comorbidities that had to be concerned as to whether or not this virus was going to aggravate those, which is where we saw a lot of the deaths. So I would love to share some of that research. We have a new fellow coming on at Brookings from the Johns Hopkins Center. So when we get closer, I would love to share your story too.
That would be great. That would be great. We'd love to continue to have an ongoing relationship. One of the questions that came up from somebody was, you talked about how rich and full people's stories are, right? And for us, we very much believe that a lot of our work in the policy space needs to be informed from having your finger on the pulse of community, right? Grassroots, level information. How do we create patient-centric models? So when we're talking about telehealth and technology, where patients can get the opportunity to choose how they want to engage with their healthcare provider.
That's tough. It's tough for a couple of reasons because the healthcare space is still sort of bound by the HIPAA requirements and in the absence of any type of federal privacy standard when it comes to what you can share online. There is some trepidation of what people want to put out there because now we're seeing sort of the spiral effect that your information can land up anywhere or it could be hacked. I think this is one of those cases, and as a sociologist with a PhD, I always tell this to technology companies, for example, who are trying to jump into the space and sort of collect these narratives, that it's important that you engage people from the beginning in these conversations. And so again, going back to the pandemic, I think what the administration did differently to sort of help in that small window of time where we saw an increase in vaccination was to have the storytelling come from within and to leverage the assets of people to share their experiences with the vaccination. So you saw a lot of ad council stuff. I got it. This is what happened to me. People walking in the community, pastors, etc. So I think the best way that if you want to start with a patient-centered approach, unfortunately, you have to start with trusted people that are work alongside of healthcare providers to sort of help embody that experience. The other thing I would say too that technology does afford though is social media, and the ability of people to come into like-minded groups. Now, for all the things that social media is not good for, those things it is good for. I can tell you right now, because I'm doing this crash keto diet, and if it wasn't for my social media community, I don't know how I'd be sitting here today. But there is something about people sharing their patient stories through, social media properties. You can see it from anywhere from social media like Nextdoor, which is more of a community-based tool, to, your international Facebook platform. How you actually set up those groups and those affinities, I think will matter as long as you can find ways where you have certain standards in terms of the content and certain privacy provisions baked into that group. Mm-hmm. But it's a great way. We're kind of thinking about this as well at Brookings because social media companies do a whole lot of bad stuff oftentimes. But there are things that we find that, I was talking to a woman in here who has put together a group for Black women who are trying to get healthy, who have a lot of chronic conditions, and it's also for weight loss. She's got 20,000 women in that group, and in that group they have subgroups now of people with lupus and other conditions, and that's sort of, again, how do we find a safe space in technology to help us to develop those platforms? And for all of you, sometimes the platform is not Facebook, it's the platform that you're developing around Facebook, which I think is the key.
Absolutely. And it's interesting you say that. One of the things that we saw very early on in the pandemic that was very interesting is in the substance abuse and mental health space in terms of group work. folks were much more willing to attend a meeting because they could keep their camera off and they could simply listen and participate and start to absorb some of the wisdom and some of the camaraderie that's shared.
Yeah. And if I could say on that, like in my book, one of the areas that I went to had a high rate of opioid addiction. And part of the research question I had in my book is, we have this power of technology to get to people. And are we actually leveraging that power of technology to get to people? And it's unfortunate, which is why I keep bringing in these connections between these inequalities, that oftentimes we can't leverage the technology because people are too poor to keep the technology on, right? Or they have it shut off one day and it's on the other, or they live in areas where they don't have access. But, you know, again, I think there's a conversation worth to be had. And I sort of mentioned this in the book, that when we start looking at these traditional legacy systems and institutional structures, we can turn the table on technology to be an enabler, as opposed to be something that is like passively consumed, where people have it, but they're not necessarily using it to contact 911 if they're going into some type of, overdose alert, or they're not, we've got to get people to see that this power that they're using to stream videos and music has as much usefulness in improving the quality of life. And that's a big question for me because, again, to your point, there's so much work that has to be done out there.
Absolutely. One of the questions that was sent to me, you mentioned early on, the issue around reimbursement of care to providers. So for providing telehealth and helping patients to get connected. What is your thought, or what is the thinking at Brookings about CBOs, community-based organizations, in terms of reimbursement models, right? Because I think you very eloquently identified that it's not just access to a healthcare provider. If I can see my doctor 3 times a week and I have diabetes and I have to order off the dollar menu at McDonald's, seeing my doctor is not going to change the dynamic in terms of my healthcare outcomes. But one of the things that we see happen a lot in our region is there's a reliance on community-based organizations to provide, for example, in a crisis, food security, or to provide, mental health care without payment for those referrals.
Right.
And that's not a system when folks are, putting rubber bands together to try to be able to provide services. And it certainly is not a system that promotes the highest quality of care. So what are your thoughts in terms of the way to integrate healthcare systems and community-based organizations that provide social determinants of health?
I think that's a great question. And I think that's one that we have to impress upon policymakers to sort of look themselves in the mirror and say, hey, you relied upon all these CBOs to help you in these vaccination efforts and to help sort of mitigate the distress that was on hospitals. Why aren't they getting the eligible and necessary funding to do those things? Now, the argument has always been made, with community-based care, that you have the right credentials, which I know I'm not saying speaking out of turn. When I was in Chicago as a student working again alongside that young woman, the community care clinics were pretty much privately based and they didn't have connections to the CBOs, right? They were sort of the place that people got seen. And if you all remember, I'm a little older than I look, but 20 years ago, a lot of those places were overbilling and overcharging, making the case for not investing in local community care. So I think today, fast forward, we have much more quality provision of care. We have much more quality standards, and we need to expand upon that money. I mean, I think part of the challenge is in the United States prior to pandemic, everything was done by this particular book, and the pandemic has appended all of that. And the only way that we're going to impress upon the fact that we need more funding for community-based care, we need more funding for community-based organizations that partner and sort of triage that care, is we're going to have to speak to legislators about that. Unfortunately, it does not happen unless you speak to legislators. I'll send around to the group Congressman Clyburn's remarks as part of the podcast. I mean, he talked about this in terms of how do you start putting community-based care as a priority, particularly places like rural South Carolina. Same thing in Long Island, right? There are places that people cannot get access to care without a 2 to 3 hour trip to an institution. They should be able to do this. So again, I would say keep impressing upon the need to continue telehealth as a broad federal action. And then 2, impress upon, as all this funding begins to expire, how do we keep some of these national experiments and pilots up to par so we can get money to the entities that need it the most?
And probably at the state level, that's really, making, working on a system that the managed care organizations are reimbursing for these services.
That's right. I mean, the challenge is, and this is what I think is going to happen at the expiration of the waivers. The waivers, I've been doing this Rebecca, for 20 years. I've seen like experiments in telehealth off of the remote islands of Alaska. You know, I've seen in the mid-Atlantic, Virginia. I've seen it in New York, up in some of the areas in Albany. And it took a stroke of the pen to allow for it.
Right.
The challenge is, you know, we may go back to the same old processes, much like we're trying to get kids back into the same old schools because we haven't reimagined healthcare. And so, you know, I think the government in some respects, and I may be speaking out of turn, may think, well, by pushing for more actors in the health exchange and making the cost of healthcare more affordable is just the one bullet solution. It's not. We need to also focus equally on quality of care and provision, who's providing that care. Because I think that will help us much later when we deal with maybe a similar circumstance or other areas of fear and frustration when it comes to these mandated or, you know, these recommended vaccinations to sort of quell these viruses and maintain public health overall.
Absolutely. And you're certainly speaking about something that we are not only advocating about, but really talking about a lot, which is we can't return to our pre-pandemic Long Island. It was, you know, one of the 10th most segregated regions in the country. You know, when you look at our numbers, well over 30% of Long Islanders can't afford a basic survival budget, and we need to really think differently about our systems. One of the questions that came into the chat are, would you speak please to the pandemic as a probative case study for high quality universal healthcare divorced from both the insurance business and employer?
See, yeah, that's a whole nother panel.
It is.
That's a whole nother panel. Well, I think that's where we're starting to see these arguments around value-based care, you know, mount up, because people are starting to say, well, maybe these frameworks don't work well, you know, in terms of just looking at employers or looking at, you know, the traditional systems of healthcare and healthcare provision. Maybe let's go to value-based care. And so we've done a couple of things in Brookings, for example, with, you know, Doctors on Demand. And I was on an NPR radio show with a woman, I can't remember her name, but Dr. Teesberg, who has been talking about value-based care, which I think is going to be a big question when we get to, again, the end of the year. If we're going to continue telehealth, it obviously has to be paid for, right? But one of the things that we have to avoid falling back into is a patient's decision on whether or not they want to see you in person or they want to see you online, and whether or not they think the value is going to be the same, right, between an in-person or online visit. Now, obviously, there are things that people still have to go in online. I just went in and got my physical just the other day. They had to take my blood work. There are things that you cannot do over the computer. We are not in the space of, you know, the Jetsons, where someone can take your blood via the internet. But I do think that these are conversations that we just don't have enough time to discuss. But I do think, again, looking forward, and I'll stay in touch with this group, looking at what the landscape is going to look like as we come out of this pandemic is going to be interesting. Will there be certain areas where telehealth will be more preference, like telepsychiatry or mental health and substance abuse? Or will we want to see it more universally deployed and give patients and doctors that option? Will we be able to take it to lower income, geographically isolated places? If we can't necessarily bring a computer to them, I've actually been suggesting people do like we did with the libraries. When I grew up in my hood, we didn't have a library. So we had the library book bank, the mobile book bank. Will we go back to those areas? I just want us to keep thinking about these spaces, because I'm hearing more and more from different journals that the lack of care for some people, some communities who didn't have access to telehealth to check in with their doctors is resulting in increased rates of breast cancer and other things that we're now seeing. This is all going to be a current experiment with 5-year results. And so I think it's just important for this group and others just to keep these questions top of mind while there's some political will and interest in the topic.
But I do think, to your point earlier, it's going to have to be almost surgically studied, right? Because different groups are going to have very vastly different experiences and outcomes.
That's right. That's right. I know we're out of time, but I also think it's important, and this is a digital divide piece. When we're thinking about telehealth, I was just telling someone I'm going to start writing some policy pieces. Why aren't we advocating for the reimbursement of tablets or digital health tools if we know that those are going to be quality of life monitors that will help us reduce some of the latter fiscally deep costs that come with the lack of management and real-time care? So things like that, I think, again, we need to keep talking about as we think about how to bridge these two worlds.
Absolutely, absolutely. And I would say, you know, when we think about DISRIP and we think about the investments, that this is exactly what we're talking about in terms of reducing costs. So I will ask you one last question that came from the group. So folks said that they're very excited to read your book.
I am too.
Congratulations. And is there any other anecdote or story from it that you love that you haven't shared with us yet, or that you could tell us as a teaser as we wait for it to be released?
Oh my gosh, I have so many. I have so many. You know, on the side of reality, so the dose of reality, I'll share two because they're also interesting in and of itself. But I'll share one on the side of reality. Stanton, Virginia, I went to visit. Oh no, Marion, Alabama, rural South. First time going there. I'm a New Yorker. So it was a really interesting experience to drive to the rural South for the first time, even though my family's from there. I had met them, but I rode through myself through Birmingham to Marion. And I met a very extraordinary principal who I've actually stayed in touch to this day that has 700 students in a consolidated K through 12 school. All of them have tablets through the previous administration, Obama administration's Connectedness program. And what was so wonderful about this is they use these tablets at home. And so one of the stories that I held that's actually health related as well was a parent that I spoke to whose kid is so excited about having the technology at home and in school, but the mother was able to use it to find another job, stay in touch with her doctor. She also experienced late stage breast cancer. And the reason that that story is optimistic is because that woman is an extraordinary leader. And she basically, she was on a PBS NewsHour feature with me just recently. I had recommended her. They went down there. But she came out, she said, I grew up in this community and I'm gonna make sure each of these kids have an opportunity that I didn't have. And we're gonna do this through technology. And on a positive side, that's a little less complex as the one in Marion, Alabama, was this trip to Garrett County, Maryland, where I visited a 5-room school in an Amish community where they didn't have the typical broadband that we have, which is from our major telecom providers like Comcast, AT&T. They had something which was called TV Whitespace, which is a local mesh network that went from the school to this really interesting antenna. I actually wrote about it on the Brookings website. You can find the story. But her school, again, a 5-room school, 50 students, were Maryland State's national champions when it came to robotics. And it's an interesting story because the Amish do not necessarily embrace technology. And so what she basically said is what they do in school stays in school. But the fact that they are learning skills outside of the wood trades is actually really important to her. And so these stories, in addition to like the big policy issues that I want to actually solve after doing this for 25 years, I mean, that story that I shared about my colleague came because I was working at a computer center in a public housing development in Chicago. I've been in this for like 20 plus years. But these stories are why I do this. And that's why you hear me and you see all this passion and energy because, you know, I want to humbly give credence to the people that raised me in this space to be a policymaker in DC as a sociologist. But also these last few years have been just an incredible filling of what real life is like, because we often can get confused when we live out in the Beltway and we're just among policymakers. So this has been a great opportunity to be home and speak to all of you.
Oh, it's been such a privilege to have you. You just are an outstanding human being and an exceptional leader, and your passion and your energy is contagious. And it certainly has, I know, catalyzed everyone on this call. One of the things we talked about at the beginning of the conference is that this isn't a conference, it's a call to action. And so thank you so much for making that call loudly and powerfully. And we are so excited to read your book, Long Islanders support Long Islanders. So, you are home and we are excited to continue to work with you. So thank you so very much.
Thank you. Thanks for having me. And I'll be in touch. Let's stay in touch and let's keep talking. Thank you, everybody.
Thank you. Thank you so very much. Next, I am very pleased to introduce our controller, Jack Schneerman, who is going to share some words with us. There's no volume. Hold on, we're gonna fix that. 1 second. Can't be a technology conference without having at least one technology issue. So we'll give it a minute as my team fixes that. Give us 1 second.
I'm Nassau County Controller Jack Schneerman. I want to thank Rebecca Sannon and the Health and Welfare Council of Long Island for hosting this event. There is no better time for health equity. Now is the exact right moment to be talking about driving equity through technology. And I'll just say our team here in the Controller's Office has focused on so many of these critical issues of equity over the past 4 years. We've released a demographic profile of our county that shows we're rapidly changing, we're getting older, we're getting more diverse. And it shows that we need to deliver the services to the population of today and tomorrow, not a generation ago. We've got to talk about technology, driving modernization, and achieving equity together. And we need to ensure that our parents and our grandparents have the ability to live here for years to come and to keep the next generation here on Long Island. We talk a lot about modernizing the deal of living on Long Island in our office and how we live, work, and play here affordably. And it is a challenge, from health equity to housing, veterans issues, food insecurity. There is so much work for us to do together. We need to listen to the folks in our communities to craft solutions together that raise all of us up. So thank you again to Rebecca, to the Health and Welfare Council, and to everyone here today. Thank you.
Thank you to our wonderful Controller Jack Schneerman. I am now very happy to, first of all, let me just thank again Morgan Stanley, our platinum sponsor. We have lots of fantastic sponsors. Now, please join me in welcoming Jeff McQueen. Jeff McQueen is a champion of mental health equity for over 2 decades. He's active in our sector and in our region. He is the executive director of the Mental Health Association of Nassau County. He's also a member of our, at Health and Welfare Council of Long Island's, our Health Equity Alliance steering committee, and just an incredible partner with our organization. He serves as co-chair of our Disaster Response Coalition COVID-19's Behavioral Health Subcommittee, which is all about, making sure that as this crisis emerged of COVID-19, that we are addressing the incredible mental health and substance abuse issues that are facing our region in a way that is culturally competent and responsible and thoughtful. So Jeff joins us to talk more about where we go after today. Jeff.
Thank you very much, Rebecca. I think that this is just a great opportunity for us to reflect and look at what the pandemic has brought into our community and into our organizations, how quickly it required us to find out how resilient we are in the work that we do, and devise new ways to be able to not just interact with the people that we serve, but just with the community at large. And in the midst of that, we also found ourselves very challenged to look at our own biases and to be able to make sure that we were doing the work that we do through a focused lens of equity, right? Diversity and inclusion. And so now here we are at this place where, and this is the perfect the webinar and panel and to be discussing this. And I also just think that it challenges us and forces us to look at how we move forward. Where do we go from here? How do we take the information that was kind of forced upon us and that we had to adapt to be able to continue to stay vibrant in our community and make sure that we were connected to family and loved ones and the people that we serve who desperately need us to stay vigilant in our own process, to keep our organizations up and running, to provide them with the care that they need. And so this challenges us to look at where do we go forward? How do we make this work? And I think that if we listen to the information shared throughout this webinar and from these panelists, we get to internalize and self-reflect on what it is that we need to do to make sure that we keep ourselves innovative, connected to what technology is bringing to our world and to our field, and making sure that we continue to do this through an equity-focused lens, right? Like, we can't continue to go forward with old information and with old ways. This is challenging us to change who we are, to conform to what is best or what is best practices and what works best for the people that we serve and for our communities. And so now it's just a call to action that says, let's be better, let's be greater, let's do more, let's connect better, and let's even love more, right? Let's make sure that who we are really embraces and harnesses our true nature as human beings with the rest of the world and with those that we serve, without the biases, without the divisions, and making sure that we do that in the best way possible. And so enhancing technology and moving forward in a way that is innovative and collectively and collaboratively working with others, because now we can't stay in our silos anymore. We need to work with each other and come together to be able to be the best we can be for our community and for Long Island as a whole. And I think that this panel coming up will really give us some clear understanding of what that looks like. And so next week, we just have a wonderful panel of experts and leaders who are working in a variety of fields, both locally and nationally, and are transforming how we work together with technology through an equity lens, right? Keeping that equity in mind. And so I'm just pleased to introduce to you the moderator, Sammy Chu, who is the CEO of Edgewise Energy and also a board member of the Health and Welfare Council, who will introduce you to this great group.
Thank you. Thank you so much, Jeff. And I'm just going to jump in for 1 second and say a couple things. First of all, I just love what you said about loving people more. There have been a couple moments throughout this conference that I think have really stood out and touched my heart. One of them was earlier when we talked about systemic equity and thinking about how we drive a concept forward of what we really want to see happen here in our region. And I think you just hit another moment for me of really, thinking about all the work we do in terms of how we love each other, because COVID-19 has taught us more than anything else that we need each other and that our well-being impacts each other. So thank you so much. And, just quickly to add to what Jeff said about Sammy Chu, the CEO of Edgewise Energy, a valued member of our board here at Health and Welfare Council. He's really spent the last couple of years focused on clean energy and building opportunities for the next generation with Edgewise Energy. Previous to that, he served in the Suffolk County Executives Administration, Steve Ballone's administration, where I had the privilege of working with him. And prior to that, the town of Babylon. And we are so fortunate today to welcome leaders in technology and healthcare and in grassroots community-based service. Each of them has really witnessed a different facet of this digital divide and have been trailblazers, really fighting just tirelessly to close the gap and achieve a more equitable Long Island of systemic equity. So thank you. And I turn it over to you, Sammy Chu.
Thank you, Rebecca. It's really a pleasure, honor to be here for such a great topic. This is, as you know, this is near and dear to my heart. Rebecca and I work very closely. We're both recovering, public officials, but we work for Sandy, to address a lot of issues, and there were a lot of issues that were related to people not having access. And I think, this is such an important conversation because people talk about progress all the time. And it's certainly, I don't think anyone can deny that there's been a lot of strides and advancements in technology. But unfortunately, historically, what's happened sometimes when there have been, in fact, in just about all cases, when there have been these advancements, not everyone comes along, not everyone gets brought together, and that progress is not equitable. So I think, we have a group today that is very much working in their daily life, every day to make sure that we come to an understanding here on Long Island and as a country, and just globally, that there is no progress unless that progress is equitable progress. If there are people left behind, if there are people that don't have access, that's really not progress. That's just, creating this bigger divide. And there are some people that are just, historically have always, been left behind. And this is the right group to have a conversation about how or we are going to attack that. We have a lot of, I thank everyone for joining us today. I see we have a ton of participants. Thank you. We have a lot of great panelists, and we don't have a lot of time. So I am going to jump into introductions. I am going to let you know who's with us today, and then I'm going to allow all of our panelists, give a little introduction about the work they're doing, day to day. We are joined by Kira Armstrong, Senior Consultant for Healthcare Improvement, Intrepid Ascent, Jacob Dixon, who is really a pleasure to see you. Jacob and I haven't seen each other for years. Founder and CEO of Choice for All, a wonderful Taylor Justice, co-founder and president of Unite Us. Dr. Stacy Lindow, founder and CIO of NowPow. Sophie Lou Barbieri, vice president and chief applications officer from Northwell Health. And with that, I am going to come around to Kira. Kira, if you wouldn't mind just giving a short introduction of what you are working on in day to day.
Great, and I'll try to keep it really short to honor the other panelists, but I work with a small consulting group based in California, and we have supported a lot of kind of cross-sector collaboration projects in both California and New York, other states, really trying to solve the problem of how do we build both the agreements and trust and select and implement technology tools to support cross-sector collaboration for the most vulnerable members of our community.
Great, thank you so much. Jacob, and I think you're still on mute. I think you could all take yourselves on mute.
No problem. Thank you, Sammy. It's good to see everyone, and good afternoon, everybody. My name is Jacob Dixon. I serve as the founder and CEO of Choice for All. We're a nonprofit that provides direct services and promote community-led campaigns to advance education, health, and economic justice across Long Island, but we're primarily based in Roosevelt. I'm also a steering committee member of the Health Equity Alliance. So I work with Jeff along with Health and Welfare Alliance, and also was the pilot community with our NowPow collaboration project. So I'm glad to be here to provide some feedback from our own and on the ground on up about what this means to us. So thanks, Sammy.
Great, and Taylor?
Hi, this is Taylor Justice, president and co-founder at Unite Us. Unite Us is a community-wide care coordination platform really focused on connecting social care with healthcare, with an emphasis on how do we bring nonprofit organizations in the community to the same priority level as healthcare as we think about an individual's overall health. So thank you.
Terrific. Dr. Linda?
Good afternoon. I'm pleased to be here. I'm Stacy Lindow. I'm founder and chief innovation officer at NowPow. And NowPow is a community resource referral technology company that spun out of my lab at the University of Chicago, where I'm a practicing physician and professor of obstetrics and gynecology and medicine geriatrics.
Great. And Sophie?
Good afternoon, everyone. It's honestly a pleasure and an honor to be part of this conference. I am the Chief Application Officer at Northwell Health. We are a main healthcare provider out in Long Island and throughout the boroughs and extending beyond the coast of the East Coast. We focus very much on the pandemic response, and we continue to deliver our community and pop health services and continue to serve our community and partner up with our community. And looking very much forward to this panel.
Great, thank you. And just so everyone knows, in the materials that you should have gotten your emails when you registered, there's full bios for everyone, but everyone here is so accomplished. If I had read all of them, they would have taken the entire duration. So I encourage you to go and find out, research everyone in the materials. I'm just gonna jump right into some questions. This is not, this is directed to the whole panel. So how has technology transformed the way health and human services are provided? And in particular, what are some of the lessons that you can point to that have been learned over the course of the pandemic so far?
Well, I'll jump in to start us off. As a practicing physician over the last 25 years, I've seen a huge, I've seen a huge transformation in healthcare as a result of moving from paper and pencil, remember prescription pads and scribbly paper charts, to a digital operation. That transformation was driven by the desire to bill better and some safety concerns, especially focused on errors in medication prescribing. So over the last 10 years, most of the healthcare system has gone digital. And it's only recently that this technology has been put to use with a focus more on the patient or the consumer. We're not where we should be. Why can't I text my medical record to have it tell me when was my last COVID vaccine or when is my next mammogram? I mean, that's really where we ought to be. Now, as a physician whose job it is to take care of people's health on the south side of Chicago, I also need to know, where are all the health promoting resources in my community? Where are all the vital human and social services organizations that my patients need to take care of their health? And that piece of the health and human services world has not gotten digital yet, for the most part. We've really left community-based organizations out of the digital transformation. And this just furthers the inequities we've already been talking about today. So where we are now, and with COVID, accelerated, I would say, by COVID, we're moving to a world where all clinicians and carers across communities, healthcare professionals, and community-based service providers are regarded as vital to the health of people and communities, and are connected. And in an ideal state, as COVID would show us, we all know where the vital resources of our communities are before disaster strikes, because we all need to be able to take care of our health in good times and in bad. Now, by bringing the healthcare system and the other sectors together into a digital ecosystem where we can share information, we can see what each other does and make referrals across these sectors, we not only more efficiently meet the needs of people, but we generate data at scale that then can be used for our advocacy efforts to ensure equity. Do all people have equal access to food supports and basic needs? Do all people have access to the resources they need to manage with diabetes or hypertension, or to be good caregivers for other people? We can only know that by bringing these activities to digital scale, and then using the data that are generated to advocate for equity.
Yeah, and I'll tag along to that from a tech perspective. You know, I think to follow on Stacy's comment there, when we talk about health, I think everybody's mind just turns to healthcare. And I think that narrative, fortunately, is starting to change across the country of, do you have a roof over your head? Do you have access to an employable wage? Do you have food in your belly? And I think what the pandemic has highlighted is we don't have the appropriate infrastructure to really prop up human and social service organizations that have historically had to be dependent upon philanthropic funding or government grants that we all know are at times way too restrictive, not a lot of wiggle room to innovate. And then especially in the pandemic, when you see organizations that had to shut their doors or had to limit their services, but the demand only increased tenfold. I think the where technology can help is, who are those organizations that are open? Who are those organizations that have historically had to do more with less? And how do you rebalance our priorities as a country? And I think the focus on health equity, technology's role there is about, how do you remove barriers to access? How do you help organizations that are on the front lines do their job more efficiently so that they can operate at the top of their license, so that they don't have to Google search, that they don't have to take a brochure, send somebody out of their doors and hope they get those services, and not have to coordinate care through Excel sheets anymore. So technology's role here is kind of twofold. How do we improve a process? And then how do we leverage that information of what's tactically happening on the ground to reallocate appropriate funding to the community so that they have the resources they need to be healthier? And 2020, I think, highlighted that for everyone. And technology is a piece of that puzzle to prop up communities, to prop up nonprofit organizations, to be able, and I don't want to say compete, but to have the same tools that allows them to operate at the same level as healthcare, because it isn't always looked at as the same, but it should be.
So on that, you know, and I know the experience. I had my own frustrations. I lost count of how many, you know, COVID tests I had to do. And now that I think about it, honestly, I don't think I could have done it without a cell phone if I didn't have it, and without internet access. I just don't think it would have been possible. And not to mention the wherewithal, you know, and not all the systems are great. You know, so what are, and this is a big, you know, a very big consideration, you know, but what are some of the key short-term considerations, you know, for the health and human services sector, you know, is look forward towards, you know, a sustainable way, a longer-term sustainable way, you know, to integrate technology into equitable care. What are some of the key things we need to start with?
Well, I'll jump in, and I encourage, of course, the others will jump in as well. But you know, I think one of the things we're learning, I'm sort of a student in this emerging field, as I think a lot of the folks at this table are. And one of the things we're learning as best practices for really trying to figure out how, as Taylor said, the technology can really serve the community-based organizations that are out there doing the work is really start small and define your use case, define a use case that really comes hopefully from a community need, and build from there. So, and I know that HWCLI has really modeled this example in the way they've started piloting with NowPow, for example, of in their case, the use case was a location, I think, sort of small, start in the community and really work with that community to define what the network and the technology is going to serve there. And then I think you can kind of start to demonstrate the value and how the technology will support the folks doing the work on the ground. In other areas that I've worked in, they've also used programs, you know, so sometimes we do have to respond to the funding realities in an area. So in California, there's a lot of work about ACEs, kind of building the use case, the initial use case for how are we going to kind of put that technology to work to support the community. Whole person care is another initiative in California that's really sort of built the reason for cross sector collaboration and allowed the groups to come together in a technology to build the trust and the framework to do the work and support those organizations.
Great, thank you. Anyone else? I mean, this is really this question is at the heart of what we're discussing. You know, what are the key steps? You know, the first key steps that we need to start with to make this an equitable space, or at least get on a path to it.
One thing I would add is thinking about people as whole people. I like the approach of starting with a burning problem in a community. What does the community identify as its priority? And how do we solve that by leveraging existing assets in our community? And technology and the data that come from using the technology can and should inform that work. But people, even when we focus on a specific problem, let's say it's food insecurity, where I focus a lot of my work, a person with food insecurity might also have diabetes, might also be caring for a parent with dementia, might also have a child who needs summer employment or tutoring. And so we want to design tools using technology information that maybe meet people who've been drawn in for help for a specific problem or to meet a certain challenge, but recognizing that as soon as we engage with a person on that challenge, we open up and we come to understand them as a whole person. You know, in the medical model, we never would have built a medicine prescribing system, like one for hypertension and one for asthma and one for kids and one for old people. You build one system that works for whole people. And I think that's a really important principle as we think about bringing technology to solve for big problems and promote equity at the level of communities.
I think one other thing that brings up for me, Stacy, is the need for interoperability across tools. You know, you mentioned that the whole health sector has gone digital, which means there are 100 EHRs out there, electronic health record systems. There are two of many really amazing tech innovators here at this table who have solutions to offer for resource directory and referral type functionalities. There's a lot of care coordination, other types of care coordination tools. I was just on a listening session with some other kind of experts on the West Coast who are working on this in this field. And one of them was the San Diego Community Information Exchange. And they were really saying that they started their initiative with interoperability at the forefront so that they wouldn't leave anybody out. They wouldn't create siloed systems in their area, a large area in Southern California, because people are coming to the table with their own internal systems at the table. And in a region, there may also be multiple tools chosen for really good reasons by local communities to do similar work. And so just as technology innovators who care about equity, we really need to be part of the solution with interoperability to make sure we're knitting together communities so we can do that whole person care. We're not leaving out a sector, or we're not leaving out a region of our community.
Yeah, I think that's really important too. And maybe I'd love Jacob's view on this too, coming from the community aspect. But I think when people say interoperability, it goes back to what I was saying before, as they think about healthcare. Like interoperability to me, and what's also important is healthcare isn't the one that's going to address social determinants of health. It is the organizations in the community that do this work. So how are we interoperating with them? What are their needs, and how are they being given value to want to even participate? Because what you see is you can pull all the data in the world, but how do you actually solve this problem? Technology is not going to do that. Technology is going to get you there quicker. Technology is going to highlight where gaps are. But then who are the organizations that now have this information that can take that where previously it was siloed and sit in a bunch of different buckets, and then say, hey, no, look, this is what's happening in my community. We don't have food. We don't have access to an employable wage. We don't have different services that we need. And here's how we can help. And to me, interoperability, it is super important that you have an integration with Northwell Health in your community. It is far more important to me that all of those community-based organizations see value and want to participate in a system if you actually want to address care. Because if we only focus on interoperability, we'll be stuck in identifying someone has a problem, not actually addressing it.
Taylor, that's a great point, that technology didn't necessarily create all these issues, but it's exacerbated the gaps. And I'll follow up to put we can put Jacob on the spot. The cross-sector collaboration that Dr. Linda mentioned. We saw this during the Sandy recovery when I was working with Rebecca back then. The utilities had different we couldn't overlay utility information with municipal information, and it really made a challenge to get to the most vulnerable populations, especially because they didn't have great access. So how are we going to overcome this, cross-sector, collaborations and intersections when each sector in itself has its own bureaucracies and has troubles becoming uniform? Jacob, I know you have some answers for this, so we'll put you on the spot. How do we get there?
I don't know if I have all the answers for that. That's why this collaboration right here is important, right? In this space. But I think it's important first and foremost that this is definitely a discussion that we consistently have ongoing as the Health Equity Alliance, where we have, over 200 different organizations from different sectors across the board about how do we all fit. Whereas, folks who work within the homeless have their own systems versus those who work with food insecurity. And then how do we cross communicate with one another? But I go back to this main point about the end user. And it's really ultimately when Stacey said that, looking at people as the whole, Sammy, when you said, I relied on my cell phone, I'm thinking about the senior who doesn't have access to phones, right? And so as we're going through this lift about, what is the shared vision, I often talk about, as much as our community-based organizations get an enhancement in their work, how are we also addressing the tech divide within the communities at which we're serving? Because if we're ultimately transforming our own systems to better communicate and respond to these issues, they should also have access to what we're talking about, and also making sure they have access to those resources in order to do that. And so I think that's one important piece when it comes down to the shared visiting across collaboration is, what is the end user going to experience? So by me having this technology and tool, this person shouldn't have to go through the trauma of explaining their issue again to the next person. At that point, if they came into my agency, Choice for All, and let's say we use our NowPow system, and then we communicated over our referral to another organization to have them handle a childcare issue, the goal would be is that they don't have to repeat their story. One time is enough within their case manager here. The goal is that it's a partnership for them to then actually get that child secured in their childcare position and where they're at. And so for me, I think it's important that we keep that end user in mind. I also think it's important that we're clear with the intent of how technology supports and not necessarily become a barrier. I think often, in particular within community-based organizations, particularly small ones who are in, or those who are in the priority communities that have hard to reach populations, one of the key things is about they may not have access to all the tools and resources to do it. So when Taylor was talking about the Excel documents and the emails, I was that organization, truthfully, we were there, but it worked within my caseworker who was used to her system and her way, and we were able to increase that. And so we had to have an intentional conversation about how do we invest in the people power in our organization and having them see how this technology will help enhance and supplement their pieces. Because I feel as much as we can have all the what they consider I hear her in the back of my hand, fancy gadgets, but really it's not, it's a way to help support it. How are they at the end going to be able to get the end user towards their goal? And I think the last piece for it also is being clear with what is an end of a referral. What is the end goal of when you do this, right? Because oftentimes we may think a service is just simply, hey, I got this person to the next organization. But for us at Choice for All, it's to close out that loophole to make sure that the food is in their belly, as Taylor said, or the fact that Stacey said they're able to go to their doctor and get the resources that they have. It's actually receiving the service and they're well off. And sometimes when we're not clear with that intention, we have two different meanings, but we're all using the same system. And so I think it's important that we have to have those points of clarity, but at the end, it all connects back to the end user and not ensuring that they go through the same exact experience over and over again, but they feel well off. And so those are the pieces that I think are really key. But I just keep going back to that word clarity and intent. I think it's very important. We may say vision, but vision requires all of us to be on the same page. And I would rather make sure that all of us leave the table knowing what each of our roles and responsibilities are to make that happen.
Then a flawless process to a terrible outcome does nobody any good, right?
No, it doesn't. And it's hard. And it's hard work. I mean, for us, when we identified what we had to do with the NowPow program in itself, our particular focus was around heating and cooling assistance during heat program season, where there were folks that were on there, and food security. But, the issue came down to, as Stacey was sharing, was that we had people who walked with different social determinants of health, or really different quality of life issues, right? We had folks that needed services for representing their kids with students with disabilities. We had a family that was in need of housing crisis while also getting their health needs done. And so how do we connect the different systems that are within that zip code and beyond that zip code to be able to come together and communicate with one another? That in of itself was a huge feat, right? That was a full-time job in itself. But as organizations, they're looking to us to do that work. And so we had to take that responsibility as an organization and rise up to the occasion. And then how do we use technology to help us do that? And so it's definitely not an easy feat, but something that we definitely have to continue working on as a region.
Great. Sophie, at Northwell, you just going through the pandemic, you saw people that weren't being seen by anybody, right? In many cases, you guys were in the front lines of you were the only physical contact that people were having with other humans. How did you guys manage and experience these things when you were having to really be the front lines for everything?
Right. So I think the point to reemphasize that, it takes technology process and just the passion of the people to carry out, and remember, be intentional on what we are trying to solve. And not every problem is the same. Not every community is the same, and not every person is the same. And so I think the power is in the diversity, and also I think the empowerment. We need to really partner and empower the people who are providing those services and those care together. Back in what you said, Northwell Health as a whole, coordination of care is hard enough in healthcare, period. How do you provide now that coordination of care with interoperability, with disparate technology, now out to different groups with inequity in access, with education, communication challenges, and policy, really, that, and technology that may hinder that. And so we need to do that in chunks. And again, how do we do that? We basically, the resilience of people and the power of the passion of the people, that are in policy, plus those are in healthcare, plus our communities and our community policy, community practices together, that reached out, and really we utilized technology to enable that and brought care to the people. We found ways to connect and communicate and educate, And we went to the faith-based. We went out to, our partners out in Long Island and said, what do we need? Can we leverage what we have in Northwell to mobilize that? We did vans. We brought people to churches to provide, education, vaccination, and also just to partner with them to get the trust of the community. And so, it's a combination of all, and it's a lot more work to be done. And the pandemic revealed, and we need to reveal situations where we need to learn from, and we are learning from them. And we hope that we will continue, like we said earlier, this mission that will be not only an emergency response, but we are going to be able to provide the outreach and the access. And if we can't get the access, can we somehow provide the navigation and guide them and help them through human interactions between the community that is providing that care?
Great. I know it's happening in the chat because we have a simultaneous chat. So Stacy, if you would, I know it's come up. We've mentioned it. It's been mentioned a few times, but we shouldn't take for granted everyone knows what NowPow is. So if you wouldn't mind giving a primer to the entire audience.
Well, sure. And I know that Taylor will want to chime in too, but I'll speak to NowPow first and just give a broader context. NowPow is one of several companies, private sector companies, that are competing, frankly, to bring forth the best solution to enable carers across communities to connect people to the resources we all need to stay well, meet basic needs, manage with illness, and care for others. That's NowPow's pitch. Unitas and NowPow are hearty and healthy competitors, and there are several others. Aunt Bertha would be another company in this space. Healthify would be another company in this space. And I think we're represented here today because we do some collaborative work. NowPow does with HWCLI. And I think the issues we're speaking to, many of our competitors would say the same thing. I'll just say one other thing about NowPow. Our company is the outgrowth of a Healthcare Innovation Award from the U.S. Centers for Medicare and Medicaid Innovation, which launched an Innovation Award series in 2012, and we were one of the first awardees. NowPow is the outgrowth of a deep and wide community engaged effort on the south side of Chicago, which is a large, predominantly African-American Black geography. And it was a solution designed to solve the problem that both carers in the healthcare setting and carers in the broader community had, which is, what is the inventory of programs and services? What are all the assets of this community that can be brought to bear toward long-term goals around health equity and economic vitality in the region? So we tested that model with the Healthcare Innovation Award 2012 to 15, and it was an obligation of awardees to bring forth a sustainable business model. That's how I went from professor to founder, and we created this company NowPow, and a nonprofit community-based organization called MAPSCORE, which employs youth to conduct an annual census of community resources every summer, which also operates in New York, by the way.
So this is a great opportunity to ask. We're having a very atypical Long Island conversation, which is we're including people from outside of Long Island because Long Island's have a tendency to try and think we have all the answers. But those of us that have actually traveled outside the boundaries know that there's best practice sometimes going on outside of Nassau and Suffolk County, and this is a great opportunity and a great group to ask on this point. What are some of the best practices we're seeing from other communities around the country to address these health disparities that we can potentially bring back and encourage here?
Yeah, I can jump in. I think the SDOH market, and no offense to my healthcare friends on the line, is kind of been created by healthcare. This has been around for decades and decades, and the community just calls it their work. But I think a benefit, and I'll use SDOH market just for the context of what we're all talking about here. I think the beauty is that it's moving very quickly in the sense of people recognizing what's needed and what isn't needed. In many years ago, we were focused on, hey, if I just know where all the resources are, I'm going to be able to solve the problem. And then we started to get into, hey, I actually need to know, did this person receive that service or not? And now I think you start to see the need for like end-to-end solutions from a tech perspective that prop up value-based care arrangements. And so when I talked about earlier of how do you bring social care to the same priority level as healthcare, how you get healthcare to care about social care is where does it hit their pocketbook? And where does it help them actually reduce healthcare costs but improve health? And so you start to see from a market perspective, both from a federal standpoint, state government standpoint, of including SDOH measures as part of healthcare funding and as part of general healthcare. And what that brings as an opportunity is that you're going to start to see a bigger emphasis on propping up communities and nonprofit organizations that provide these services to be ingrained in that care delivery process, which there will start to be a flow of funds. But we all know that there is a very rigid and sophisticated, at times, process within healthcare, and they're going to just expect social care to meet those same performance levels. How long should it take someone to get to a housing organization? How long should it take them to receive that housing? Most people on this call probably know that that's not an easy answer. And there's usually not enough housing in a community. So how do we continue to be innovative and come up with solutions where, what if it isn't building a new building and that can only address 180 people? What if it was rental assistance for a period of time to 3 to 6 months where you can actually create a solution? But that rental assistance isn't actually the root cause of the issue because there's other underlying things that got them there in the first place. So how do you have flexible spending attached to that? You think when we think about an end-to-end solution, I think we're starting to see that the market, federal government and policy is starting to shift. But what we have to do and where technology plays a role is how can we arm our communities and these nonprofit organizations to have the same level of data, to speak at the same table with like, nope, these are the problems and we know how to address them, so that they can take those funds and actually address the problems. And technology is a servant to the community to provide intelligence so they can make better decisions. And so what we see happening is great from policy perspective. You see communities that are deploying technologies, be it NowPal, be it Unite Us or others, or San Diego CIE. Those are great, but they really only focus on serve, like this network. I'm going to build a network and I'm going to refer and I'm going to do X, Y, and Z. That's only a piece of the puzzle. You need to have end-to-end solutions, intelligence on the front end, reassessing, measuring, evaluating impact, but that has to be collective. And so we all need to understand that we're not going to be able to do this alone. Unite Us in and of ourselves, deploying technology is not a silver bullet. We are a tool. And if Jacob's organization can effectively use that and get the other organizations in the community to use that tool too, this moment in time that we have around social care will fade away. Because like it or not, healthcare and government will then go focus on the next shiny object and they'll start putting dollars elsewhere. This is our opportunity as a collective. It's just, do we have the right tools? Do we have the right team? And can we put our egos aside and actually do this as a collective rather than individuals?
Sure, go ahead.
I was just going to jump. I completely agree. And I think we're seeing in a lot of communities, like, how do we build the overall umbrella organization / structure / vision / program to hold the technology and the relationships. And so some of the best practices pieces we're seeing coming out of whole person care counties or accountable communities for health in Washington State or other places we're really trying to learn best practices from are, you need a trust, and Jacob and I were chatting about this in the chat. You need the trusted backbone convener organization who can hold the program. Like Taylor was saying, the technology can serve the vision if there's somebody leading that vision. So Healy plays a bit of that role in Long Island, Jacob, it sounds like your organization plays that role in a locality, but who is the one that's kind of ultimately driving the work forward, bringing people to the table, making sure the right organizations are at the table. And the places we're seeing really innovative work happening is, yes, there are healthcare or payer system partners at the table. And thank you, Northwell Health and organizations like yours for being part of this work. But the places where we're seeing really exciting work happening in California, Alameda County, Santa Cruz County, a lot of North Bay regions is where I'm located. So I'm kind of really paying attention to those at the moment, are where those backbone organizations are coming from the CBOs. So they're led by coalitions of community-based organizations like HEALI and HWCLI to make sure that we have community voice at the table, that we have even down to the end users or our consumers and clients and patients at the table telling us what's most important to them, how they want their data protected. And there's an organization to actually do that kind of governance, stakeholder decision-making work in a collective manner from the community-based perspective. They can, be amazing partners to healthcare organizations, but I think that what we're going to see when it will be successful is when the community voice is held and kind of incorporated from the beginning of the program design and network building. Been really important. And Stacey, you mentioned that too in Chicago. What is the communities that you've worked in? How do we make sure that we're building from the beginning, to solve the problems that people actually care about, in our communities?
One of the things we've learned from our work on the south side of Chicago is community practitioners know what's going on. They have evidence based on practice. They have expert opinion and insight. But when they bring these stories forth to policymakers or to power brokers, they oftentimes lack the data they need to give evidence to the claims. And I think DeJesus, the comment in the chat, housing wait lists, people can wait over 5 years and Section 8 is difficult due to landlords not wanting to accept. That we know that is a fact. And when we go to advocate to our representatives and to policymakers at all levels, they say, show me the data. So one way that where we started this conversation, that information technology systems, 21st century infrastructure can benefit the cause of equity for communities and health equity and economic equity, is by systematically producing evidence to give to help the practitioners and experts in communities bring forth their arguments about inequity. And if we are all operating from systems that can talk to each other, it's unlikely it'll be one system because our capitalist society doesn't work that way. But if we're operating from systems that can all talk to each other and generate data real time, like we had to do during COVID, to show what was the need, what were the resources available, where were the gaps, how do we quickly fill in gaps with pop-up food pantries where they're needed. Only with that kind of a system can we really solve the problem of people waiting, homeless or on the verge of homelessness 8 years to get a place to live. Without those systems, we are where we've been in the 19th and 20th centuries with people's stories to tell and policymakers saying, we don't really believe it. We don't see it. Where are the data? And I think back to a point that I'm sure Taylor and I agree on this, that the problem of structural and social factors that can determine health or determine illness, that can determine long life or can determine a short life. Those factors are societal, they're structural, they're systemic, and they require collaboration across all sectors. It turns out, because of the size of the GDP we take up, the healthcare sector has a powerful platform, and I think does have a role to play in generating the data and helping to advocate in partnership with community experts and practitioners about what are the problems, what are the gaps, and what are the solutions. But social determinants of health are going to require all of us, in my view. And
one other thing I just want to throw in as a best practice that we've really seen come out of whole person care pilots in California are building the data sharing agreements or multi-use consents that allow people across sectors who haven't had the culture really of knowing what they can share when, or they know what they can share when, and they're often have had to rely on faxing very specific consent forms, as Jacob, you were describing, it's a burden on people navigating systems, have to sign 10 different consent forms. So what they've been able to do in some of those counties is really build the trust framework and the governance framework that then technology tools can operate under. Some of those were lucky enough to be far enough along by COVID. One of my colleagues from Marin County spoke this morning, I think, at another panel. They had a really robust network of 40 partner entities who had a shared consent form. And when COVID hit, they could transition that immediately into getting people into housing for sheltering in place. So they had built the relationship. I mean, I'm sure CBOs have your relationships that are so important. They had taken those relationships into a structure that allowed them to really know what they can share with whom really efficiently, so that when the use case, when the problem shifted, they could still address that problem within this broad structure. So, I think that backbone organization could be one of those organizations that could help build both the kind of agreement structure as well as the technology solutions to do the work.
So I unfortunately, we're coming to the end, but I always like to end everything I do with a call to action. And we have a lot of people, a pretty wide audience here, people working in a lot of different roles for a lot of different types of organizations. So I'd love to just go around, get 30 seconds from everyone. What can everyone that's participating today, take back to their own work, to help address tech equity? Anyone jump in?
Well, Sammy, I think my tagline just within technology itself is to carpe diem, reimagine, innovate, and work together just for my teams. And I think that's ever true in this arena, and that I want to make sure that we don't lose the momentum and don't forget what we've gone through the pandemic, the good and the bad, and then continue down those missions together and lobby and focus and drive with the same fervor that we had. Because like everyone said, I think through this whole conference, hopefully this doesn't come around that often, but when it doesn't come around that often, seize the opportunity and learn from it.
Great, thank you. Taylor, I'll go to you, Taylor.
Yeah, I mean, I think mine is around accountability and everybody holding themselves accountable. I mean, we talked a lot about data here, but again, data means nothing if you don't do anything with it. And in this environment, performance matters, because literally it's people's lives. And if the data is telling you that something isn't working, don't double down on bad. It's okay to change. It's okay to pivot. We're in unprecedented times, and there's a lot of people that want to help. So leverage that information to help you make better decisions for your community. But that takes courage. And that takes the ability to make tough decisions at times. But that's why all of you are in the positions that you are. You're leaders of your organization. And you got to make those tough calls at the end of the day to serve people best. And technology is just a piece of that. Getting those other government leaders, healthcare leaders, community leaders to the table is important, and everybody taking accountability for their actions.
Stacy?
I love those two suggestions, and I'll add, ask yourself in your daily life, think about the technology you're using to do your job. Are you connected to your community with your technology? Do all the people in your organization know where to go if they need help with basic needs, if they need help caring for others or managing with illness? And what do you need to do to get there? We have to be good role models. We have to be truth tellers as we do this work. And if we don't have equity inside our own organizations, it will be very hard to bring that along in our community.
Great. Akira?
I would one thing I'm really thinking a lot right now is paying attention to policy. I think we're in a similar state in California as you are in New York. Our Medicaid waivers are coming up for renewal. And in California, the CBOs and local governments that I'm working with are really trying to lobby hard to make sure that the dollars don't just go to health systems and payers, but go to the people doing the work, as you were saying, Taylor, like the getting the money to flow to the CBOs so they can get paid for the critical services they're providing. So pay attention to Medicaid waivers. We could make some big change with those and have it be institutionalized.
Great. And Jacob, I intentionally save you for last because everyone knows where to find you. Everyone on the call knows where to find you.
Thank you for that. I would say, first and foremost, this conversation has been absolutely enriching, and it's really provided me some thoughts that for my fellow community-based organizations who are watching to, as we vision about our programs and our services, we also need to vision about technology and what role specifically does it play to help support what we're doing. And more importantly, we've had a lot of intentional conversations about the use of data, but I also want to make sure, how do we make sure that the lived experience of the people are actually the ones who are speaking on that data, because those numbers are the people that we're representing, and how are they in the forefront and how they armed with that same information as a community-based organization to lead those policy changes. And so I think it's important that when we look at this holistically, that again, the end user, the community member is side by side with us in all the efforts that we do across.
Great. I want to thank all of you. This was really a great conversation. I know it's the tip of the iceberg. There's so much more work to be done. It can be overwhelming how much work there's to do, but it's really encouraging to know that people are thinking so contemplatively about it, and by the way, collaboratively. So thank you very much, and I'm going to hand it over to the boss.
Thank you so much, Sammy. That was just phenomenal. Thank you to all of our panelists. That was just incredible. Wow, what a day, what a conference. As we wrap up today, on behalf of our staff at Health and Welfare Council of Long Island, who worked hard to put this together, and our board, I want to thank you for being with us today. I hope all of you are going to leave here today as excited, inspired, and just energized as I am, ready to take everything that we've learned and develop together both the short and long-term roadmap for how we get to a more equitable and interconnected region. As we said earlier in today's conference, how do we build systemic equity? We now need you. We need you, thought leaders, experts in this realm, to continue to work with us or to join coalitions, perhaps for the first time. Perhaps you haven't been part of some of our coalitions, to take the insights and inspiration from today and carry it into how we operate every day moving forward. I'm so grateful to our sponsors, especially our platinum sponsor, Morgan Stanley, and many of our friends who've supported us and enabled us to provide this conference to you free of charge, but also to allow the Health and Welfare Council of Long Island to continue to convene and advocate on behalf of our sector in what has just been a year in particular that has magnified need in ways we couldn't have imagined just a short while ago. We will be sending out information on ways that you can join our coalitions and join our network if you haven't already. And I hope you will do so. The future of our region, the opportunity that exists today, the critical importance of not missing this moment to really build a true movement, to build true equity, it depends on each of us. It depends on all of us, as Jacob said, our collective strength. We know that when even one child's potential, when one child's light isn't realized, that the whole region is made more dim. And so we know that the lesson that COVID has taught us above and beyond anything else is that we need each other, that our well-being impacts each other. So let's use these lessons and this movement to make America's first suburb, Long Island, the model of what it means to recognize your history and build a powerfully equitable and hopeful future. Thank you all so much for spending the day with us. I am so grateful to each and every one of you. Have a wonderful afternoon.